between.
It's on the award talk.
Okay, I've got that one right here.
Okay.
So
Go down on that one. All the way down and just about to the end. No, so back up one right here. This slide has to be on my resident talk.
okay,
So copy that.
and you want it in between this slide and the conclusions.
No, after conclusions.
Okay.
Right there.
Okay. So now we've got conclusions and that guy.
Then
And then-
perfect.
Okay.
There we go. All hell, huh?
All done. You're
Great.
set.
Yep.
I'm gonna give you a mic, but we'll wait.
Yeah.
So this you can actually put on now. I'll
You
mute
put it
in
on
the
now?
back. Yeah, I'll mute in the back. So.
Every other talk's ahead of me though.
Yeah, but
Oh.
you're a special guest, so you get the good mic.
Good how I get the mic. Okay. Where do I put it?
Okay.
What's that?
Oh, another presentation from one of the residents.
Oh, I just wear it under here?
Yep. And I'm gonna go mute you in the back so you can say anything you want. No worries.
Hello, John. My name's Sean. I'm one of the R4s helping to host
Oh,
resident
really?
research.
Miserable. Our plan is we're basically, as soon as this is over, we're gonna wrap everything up and just take it over and hang out. 'Cause
Really?
we have a barn. That's really the only reason I'm trying to fix it. I balance the camera better when I've got a glass of wine and a camera.
Steady's your tremor?
It steadies the tremor. Gets that red. Yeah, and like the AOA is going on as well, and I wanted to go
Is that
see.
still going on?
Yeah, I wanted to go see Kenny Gundle's giving a talk, and I wanted to go see what he's gonna say about stuff. So
Yeah.
exactly. Yeah, you want to review your slides real quick since you're here? I saw you made some changes at like 1 a.m. So.
Standard Sean move.
Oh, it's standard doctor move. That really truly means you're ready to graduate.
Yeah.
All right. You got the pointer
Oh.
and the
Oh my
little
goodness.
slide thing. So there's these red boxes that don't have anything around them.
Interesting.
So.
Maybe I can get rid of that real quick.
That one. There we go. It's a thing of beauty.
Perfect.
You're ready for
Where do I
graduation.
push? This button?
Yeah, go to the right, and then the big red button is the laser.
Okay.
Don't shine it in people's eyes. You're not that kind of doctor. I believe. Been awake since like 2:30, so yeah. Got the early setups. Gotta make this magic happen. Every once in a while.
I've been doing it on that, but it like blew up last night. All my pictures are blank.
Oh, lovely.
Oh, great.
Usually it doesn't happen until about 3 o'clock in
Here.
the morning when you're here.
So I did put it on another disk, and I have my computer, so I think
Okay.
we're going to be okay.
It's always good to be covered.
Yeah, I know. And I emailed some of them, the early versions to Lisa.
Alright, travel drive.
So I have 2 here for today, so it's probably UW is probably what I called them. The collaborations tonight. So Lonsdale's my second talk.
Research Day. We have some very special guests today that I'll introduce in a moment. We're doing a slightly different format this year, so we'll see how this goes. In the past, Dr. Zura doesn't know, but we've had the junior and senior residents presenting their projects. This year, we're only going to present essentially finished projects. So we'll see how that goes. I want to thank a few people, Christine and Angela, for setting this up really the whole day. And I'm sure we'll have a spectacular banquet tonight. I want to thank Ted Gross, who's not here, who has put in a ton of work to help organize the session today, and then Bruce Sanjosan and Seth Leopold, who I know have worked with the residents on perfecting their projects and their talks. A couple of introductions. I'm just going to start out. We have a few of the ABC traveling fellows who have come to Seattle from the AOA from their last stop in Vancouver. Can you guys stand up? There's Will Erdley, who is from Middlesbrough, and he's a trauma surgeon, and that's a trauma center, he told me, near Newcastle, England. And then Cameron Ainley, who's from Cape Town, South Africa, and he's a sports and upper extremity surgeon. And Lisa Tatesman and I had a great Wednesday afternoon with them at the Museum of Flight, as well as with the other traveling fellows. We also have Dr. Frank Alvine, who's our distinguished alumni for 2016. And I'm going to have Sean tell you a little bit more about Dr. Alvine, but he has gone on to incredible fame based in Sioux Falls, Idaho. So he's stuck to his roots and achieved some amazing things there. We also have his son, Greg, here, who is a spine surgeon who was actually trained by Dr. Wagner. So Greg is a foot and ankle surgeon and a spine surgeon, figure that one out, also in Sioux Falls. I'm going to introduce you to Dr. Robert Zura now. So Dr. Zura is our visiting professor for the Resident Research Day and also the banquet this evening. Dr. Zura grew up in Baltimore, and as you might expect, he's a fan of the Baltimore sports teams, particularly the old great Colts and Orioles teams. He attended the Gilman Preparatory School and then went on to the University of Virginia, where he played varsity lacrosse, I would imagine, for some of those powerhouse UVA lacrosse teams. He then returned to Baltimore to study medicine at Johns Hopkins. He ended up back at UVA for his orthopedic residency after that. Bob then did an orthopedic trauma fellowship at the Carolinas Medical Center in Charlotte. Soon after, he ended up at Duke, where he spent 12 years and put together quite an impressive body of clinical and academic work. At Duke, he was the health system director for orthopedic trauma and also the director of the Orthopedic Trauma Fellowship. His research interests include non-unions, which he'll talk about in a few moments, as well as geriatric fractures and osteomyelitis. He was the Duke site director for a large multi-institutional study named the FLOW study, which looked at pulsatile lavage in open fractures. And that study was actually published in the New England Journal of Medicine. He has over 80 peer-reviewed publications, and he has served in leadership positions for the OTA, the AOA, and the AAOS. Recently, Bob relocated with his wife and his 3 kids to New Orleans, where he's the Robert D. Ambrosia Chairman of Orthopedics at the LSU Health Sciences Center. So it's great that you were able to make it out here and spend a couple of days with us.
Like,
All right, so I've labeled it by number.
That's great.
Blumberg. You're up. Normal thing, laser pointer, pew pew pew.
laser.
Make smart choices. Of course.
We felt threatened by it.
So, turn off the stage lights. That's good. It's a keeper. Oh yeah. Just about. Of course. Those are the best kind of
She was recommended to go to a sniff, but she refused because hopefully she could go because she's just a surgeon. She did off she her dog and her medications are Ella is pending avoided. What do you want to get this guy on the eye? Yes. Correct. Wait. Yeah, I mean, it's probably, I don't know if that works, if you don't have good posture. He's getting it's like atropine, it simulates parasympathetic, but it's for the bladder. So it should make the bladder contract. So, he got it, he was trying to keep it from happening. All right. Theo, we're going to wait and see what speech says before we discharge him. If he's anything but Theo, I don't know. I paged the neuro. I did some tell me if he's clear or not.
Sean?
Yep,
You're gonna take it from here?
yep,
I'll close it out at the end.
perfect.
He has referral sent out, does not have one existing. Yeah.
Sure. Yeah, I think it's on. Whoa.
Get up to 11.
Start making our way back into the auditorium, perhaps. Dim the lights.
Need someone with the tone.
Yeah.
Xylophone bells. Yep.
Aaron went to go get them. Perfect.
And disappointment.
Infections are a big deal for our patients as well as for us. More importantly, now hospitals are concerned about infections due to Medicare penalties. And so there's been discussion about decreasing reimbursement, basically having penalties for hospitals that have high readmission rates and infection rates. And so, sort of the idea behind this study or the motivation was, are there patient-related factors that lead to longer lengths of stay and increased costs in the treatment of postoperative spine infections? And then more importantly, are any of these modifiable? Are these things that we can target to hopefully prevent increased costs, increased length of stay? So this was now a couple of years ago, but a couple of Seattle hospitals being targeted basically simply due to high infection rates. And so even Harborview was on the list as a potential hospital to have their Medicare reimbursements docked due to high postoperative infection rates. So there's several 100,000 surgical site infections a year, and about a quarter of all hospital-acquired infections are ultimately, or about a quarter of all infections are all hospital-acquired, so postoperative infections would fall into that category. On average, they account for about a week to 10 days of inpatient days, and then depending on sort of the site and the causes, infection costs based on several papers range between about $10,000 and $35,000. So sort of questions that I wanted to ask or wanted to answer are, number one, what are the hospital costs for treating a postoperative surgical site infection after spine surgery? And then, are there risk factors associated with increased cost and length of stay? So are there things that we can say are going to cause this person to be in the hospital a lot longer or have a greater cost for treating their infection? So to do this, I reviewed 3 consecutive years of essentially all patients that returned to the operating room for an IND of a spine wound, and then screened all these patients to identify those that met inclusion criteria. So I was looking for any patients that had spine surgery and had no other surgeries on their admission, which would cloud the cost data from the hospital. Excluded any patients that had non-spine surgeries. So if they had, for example, a trauma with femur fracture, they would have cost data that was essentially biased with other surgeries. And then anyone that returned to the operating room during their same index admission. So if they had still been here for 10 days recovering and their wound was continuing to drain, they returned to the OR, unable to really differentiate their costs, so they were excluded. And then any patients that presented with infection from the get-go. So for example, an epidural abscess was excluded as well. And so all the cost data was provided by the financial department. So over the 3-year period, there were just over 3,000 unique spine procedures, approximately a 5% infection rate of patients returning to the operating room. For my cohort, excluded 56 of these due to the fact that they were still on their index or primary admission when their postoperative infection was identified. So ultimately led to 90 patients, 110 total readmissions. and in total 138 returns to the operating room for these 90 patients, so an average about 1.5 INDs per patient. So looked at a number of factors to see what risk factors were associated with increased cost and length of stay, so a number of patient-related factors, but also, for example, payer status, how invasive their spine surgery was, including number of levels fused, whether or not this was a revision procedure, whether they were smokers, looking at diabetes as well as any narcotic use preoperatively, and then lab values and other, for example, urosepsis or bacteremia, if that perhaps had an association. And so essentially 9 factors were identified as being significant, and then proceeded to move on with these factors, looking at a multivariate analysis. And so the first question I wanted to answer is how expensive are these infections, and sort of looking overall at our cost numbers, at least from the hospital. And these are not charges, these are actual what the hospital estimates their costs are for treating a single surgical site infection was about $16,000. And so you can see the range was quite variable. So someone that, for example, just had a microdiscectomy and then required a inpatient stay, not even overnight, just came back, had a washout, and went home, just over $2,000, to all the way over $138,000 for someone that required a plastic surgery flap for coverage. And then looking at the index surgery, so this is their primary admission for their index surgery, and this includes implants, was $34,000. When we exclude implants, you can see the costs are almost the same, about $20,000 for an index spine surgery compared to an infection, very similar numbers. Length of stay was actually longer for patients on their readmission, so an average length of stay was about just under a week for patients on their index surgery, whereas patients who had a surgical site infection that got readmitted had an average length of stay just under 8 days. Approximately a quarter of patients required multiple returns to the operating room for INDs, and 13 of our 90 actually required multiple readmissions. So got admitted, had their INDs, thought things were stable, went discharged, and then ultimately required readmission due to persistent wound drainage. So first thing is, when do these occur? And so when do patients bounce back? And the answer is overwhelmingly within a pretty reasonable time of their surgery. So just under 80% of the patients actually return to the OR less than 30 days from their index surgery, which is important for us to sort of think about when patients do return with a draining wound early on. That's a high concern for a wound infection. In terms of factors that predicted increased length of stay and increased cost, certainly the invasiveness of the procedure, a number of levels that were instrumented and fused were significant. Having an infection with a methicillin-resistant Staph aureus, the number of INDs that they required, so obviously the more INDs required, increases their length of stay and costs. Whether or not they also had a concomitant bacteremia or urosepsis, so a distant infection as well. And then most interestingly, their albumin or nutritional status. And so these are from the bivariate analysis looking at length of stay and total costs compared to these factors. And then looking within those, creating a multivariate model, you can start to see that albumin, and this is the readmission albumin, as well as an MRSA infection and the effect that has. So for example, 1 point, essentially, I guess you could say increase on this, on their albumin, results in a shorter stay by about 4 days and decreases cost by about $8,000. So for example, having a lower albumin level would increase your length of stay by 4 days and your cost by about $8,000. Having an MRSA infection increases your length of stay by about 4 days and about $9,000. So when we look at total costs and length of stay, you can see a very linear model here. So the longer you're in the hospital, the greater your costs are going to be. You can also see the folks that were in the hospital longer had, in general, more washouts and had a lower albumin. So length of stay, pretty good surrogate for our total costs. And when we sort of look at serum albumin, those patients that have a higher albumin, approaching more the normal range, have a much lower direct cost for their readmission. So as albumin increases, costs decrease. So kind of looking at albumin, we know it's a nutritional status indicator, and from this cohort decreasing Serum albumin by a gram increases costs by about $8,000 and keeps patients in the hospital about 4 days longer. Is this modifiable is the next question. So looking also at MRSA, we found that the average length of stay for a patient to be in the hospital with an MRSA infection for their spine wound was about 2 weeks compared to just 8 days for all other organisms. And it increased costs by $9,000. And then on the average, it was about 4.3 days longer. And then patients that had an MRSA infection required more washouts, so about 2.2 washouts compared to those with non-MRSA. So this is obviously limited. There's limitations to this study and single institution retrospective review. Many factors also, can bias length of stay. So for example, a lot of these patients were required to stay in the hospital simply waiting on disposition, which can influence things unnecessarily. Also had large procedure variation. So some of these patients had surgeries as small as a one-level microdiscectomy. Others had, staged procedures and multiple levels fused. So future directions were to sort of take things next. One idea is making sure patients are ready for surgery, and so that means getting nutritional labs and nutritional consults as needed to make sure that they're tuned up and ready for a large spine surgery. Something else that would be of some benefit to think about implementing would be better MRSA screening. Currently, patients get their nares swabbed in the preoperative area, and there's obviously no time at that point to preoperatively treat them. So one thing to consider when signing up patients for surgery, especially an elective surgery, would be to treat them if they have an MRSA before proceeding with their surgery. And then also looking at costs of infection prevention. So we know how much it costs to treat these, but looking at the actual cost to, for example, screen and treat an MRSA preoperatively or to obtain nutrition labs and nutrition consults and optimize patients before surgery would be something to look into. So to sort of sum things up, we know infections are very expensive. We know they're very resource intensive. But as far as predictors for those who stay in the hospital longer and those who have greater costs, MRSA, the number of levels instrumented and fused, as well as poor nutrition status, increase costs and length of stay. Any questions? Dr. Cavanaugh.
So, someone goes to a bundled payment system, what the hospital reports as cost is a little bit opaque, right? Because, cost to them are justification for billings. So until the direct variable costs, so to speak, exceed what the revenue generated by their admission, it's not a cost, right? So an empty bed is a cost because there's a lot of indirect and fixed costs, so to speak, that are not generating any revenue. So did you delve into that in any more detail? Because it's a cost to the system.
Correct.
But a readmission for infection still.
Yeah, it's a money maker in a way, depending on how you look at it. A readmission for infection is a money maker depending on whose perspective you are.
Until it exceeds what the payer is going to reimburse you for.
Correct.
The healthcare system. It's a revenue generator.
Correct.
And that room being empty, so.
That's true. So that's something that it's tough to really look into because a cost at, in the UW medicine system versus a cost in the Swedish system versus a cost at LSU, it's difficult to say that these costs regionally are going to be meaningful to anybody, and a different hospital system could obviously have much better cost structure based on regional of the country that they're in. So no, there's no way to really know what this number that they sort of create. I mean, from their perspective, they're creating this cost based on, we know that the patients here, they break everything down into nursing costs, for example. So based on the amount of time that they're admitted to a ward bed versus an ICU bed has a fixed nursing cost. And then they look at pharmacy costs. So there's, depending on what medications were actually utilized, and they'll break things down. So there's no way to there's no way to truly answer that question. This is sort of, in this system, this is what they sort of account for the costs of this readmission and this treatment are. But those numbers are sort of meaningless.
They're incentivized to have a high cost.
Well, these numbers that they're providing are...
What this could be interesting for is try to reduce our risk when we do go to a bundled payment system.
I think that's the ultimate idea, and that's looking at length of stay as well, right? So you could say costs are so variable, but if you know someone's in the hospital for just 2 days for treating their infection versus 8 days, and risk factors for keeping them in the hospital longer, that's sort of what is part of the motivation for looking at length of stay, in addition to just looking at cost, which can be a very difficult and nebulous number.
Even with bundles, it's really tricky. There's been some study where they've done a Markov chain analysis looking at the benefits of keeping your patient in the hospital in the acute care setting versus sending them out to a nursing home. You know, in bundles, we lose control of the patient and the costs once they go to a nursing home. And that study concluded that it might even be better to keep a total joint patient in the hospital, acute care setting, for up to 8 days rather than sending them to a nursing home. However, if you have another patient that can actually fill that bed with a, you know, remunerative hospital stay, then that changes the equation. So those questions are really, really tricky to answer.
That's a good point.
That's a big deal. When we have overcapacity, we can't accept transfers for youth, right? And it becomes a true cost to the hospital, because the revenue generated by the transfer patient could be higher than what we're generating from the infection.
But all of that being said, this is very nice, and you know, you're looking at an important issue and have come up with some interesting data. So,
Thank you.
So I think as, when the administrators come to you and us and try to get the patients out of the hospital, we have you to blame when you put this data out there. You understand why they're going to do that. It's that linear association, that length of stay is cost. So it probably was frustrating for you in some ways that there weren't that many modifiable factors. Your goal is probably to reduce the cost of an infection return, and there's not that much you can do. But you've got a nice cohort now of people who were infected. Did you notice anything about that group? Because I think your greatest cost saving is going to be prevention. Was there anything that came up about that group that would allow you to prevent these infections from ever happening?
So the sort of idea was not to look specifically at risk factors for infection, but the risk factors of those that were sort of longer to stay in the hospital, more expensive. And so, I mean, I think within that, finding the fact that, you know, an MRSA for infection, for example, results in more washouts, longer length of stay, sort of puts an increased you know, desire to target specifically MRSA infections. And are there things we can do short of swabbing their nares when they're in the preoperative area, for example, you know, just to target specifically MRSA infections, I think is, you know, it's relatively inexpensive to also put vancomycin powder in the spine, in the wound, which is something that has been shown to decrease infection rates in patients that have that done in some other studies. So I think that's, you know, these things are, they cost money as well, but the cost savings would be very powerful to be able to say, yes, putting vanco powder in the wound was of some benefit. We know it decreases the risk of infection, potentially would decrease the rates of these MRSA infections as well. Nick, yeah.
Question, I may have missed it. Were the albumins drawn preoperative to the index procedure or on readmission?
So that's a good point. They were drawn on their basically when they got readmitted. So there's the, I think where you're going with this is that potentially is confounded by the fact that they have an infection, which is something that is worth saying and worth mentioning, is that these patients get admitted and they have an infection. You're expecting their albumin potentially to be lower due to the fact that it's a, I guess, a reverse acute phase inhibitor. And so that's one thing to kind of keep in mind, that this albumin may be a little bit lower due to that fact, but the fact that a lot of these patients got readmitted rather quickly within 30 days and that the half-life of albumin is close to 30 days sort of guides me to believe that it's not substantially affected by that.
Just to clarify on the albumin, so it's not an acute phase inhibitor, so the way you want to think about it there is that the patient has an infection, so they're catabolic as an infection, and the protein requirements can go up to 100% increase. Okay, so that's why the albumin can potentially go down. It's actually acute phase response. So, and the half-life is 10 days. So this is
All right. Thank you.
Next will be Akash Gupta talking on the terrible triad.
Thanks. Thanks, Sean, and thanks, Dr. Zura, for being here and for your great talk this morning. My talk is called "The Single-Stage Treatment Using Standardized Protocols Results in Functional Motion in the Majority of Patients with Terrible Triad Elbow Injuries." Kind of a mouthful when I'm talking about my research as parties, as I like to do. So, no disclosures on the fact that I'm graduating tonight, so take it easy on me. So terrible triads, as most of us in this room know, are an elbow dislocation with an associated radial head fracture and a coronoid fracture. And traditionally, this it's called the terrible triad because it leads to poor outcomes. Stiffness and instability, post-traumatic arthrosis, and pain are quite common with this kind of injury. Some research in biomechanics has shown that some treatment protocols are optimized when you fix the coronoid, fix or replace the radial head, and repair the lateral collateral ligaments, plus or minus fixing the medial collateral ligaments based on instability. But because it's a rare injury, the largest series in the literature is about 36 patients. And a lot of the studies out there have small sample sizes and heterogeneous surgical approaches. And that really was kind of my interest in this project, in that we have a fairly large series here at Harborview with some standardized protocols and kind of standard surgical approaches. And so that's kind of what drove my interest in this project. I'd like to thank Dr. Beingester and Dr. Beret for their support in this project as we go through here. So the goal of this project was, again, to evaluate our institution's results using a standardized protocol. We looked at 5 different outcomes. We looked at the early dislocation rate after surgical intervention, range of motion in those who only had the index procedure, the frequency of reoperation or secondary procedures, and the difference in range of motion between those two groups, as well as the frequency of heterotopic ossification and patient-reported stiffness. And we'll talk a little bit about some of the definitions and how we define those in just a bit. We collected data from 1995 to March of 2013, and all of the surgeries were done by 4 fellowship-trained orthopedic surgeons at one institution. We were able to identify 52 patients with 52 terrible triad injuries, and all of them had at least a 6-week follow-up. We had 65% of our patients who had 6-month follow-up, so we considered the other 35% as lost to follow-up. So the intraoperative algorithm or decision tree was kind of the following. So the surgeons first determined whether the radial head was fixable or not. If it was determined to be fixable, we started by repairing the coronoid, followed by fixing the radial head, and then going to the lateral collateral ligaments. If the radial head was deemed to be not fixable, the radial neck cut was made, followed by fixation of the coronoid, then radial head arthroplasty, and then the lateral collateral ligaments were repaired. At that point, the stability of the elbow was determined using fluoroscopic imaging to see if the elbow was stable, and if it was stable, no further repair was necessary, and if it was unstable, the medial side was addressed. Postoperatively, patients were in a plaster splint for 1 to 2 days, and then they were allowed to do active and active assist range of motion with the forearm in neutral or pronation. Terminal extension was avoided for 3 weeks. Patients did not routinely receive any heterotopic ossification prophylaxis. So this is an image of a representative case, the 47-year-old lady who came in with this initial injury, and then B and C are her immediate postoperative films, and D and E are her 1-year out films. So we excluded patients who had ipsilateral upper extremity injuries, such as distal humerus fractures or Montegia fractures, just because we felt that this would affect their postoperative rehabilitation, as well as could affect their stiffness and range of motion based on other injuries. But we did include carpal fractures and distal. We required at least 1 postoperative radiograph. For our early dislocation rate, we included all 52 patients because we defined this as a dislocation that was occurring within the first 6 weeks after surgery, and all 52 patients had at least 6 weeks of follow-up. For all other data points, we only included the patients who had at least 6 months of follow-up included. We also split the group into those who only had an index surgery and those who required secondary surgeries. So 40 of the 52 patients underwent radial head arthroplasty, 45 required coronoid repair, the LCL was repaired in 49 patients, and only 1 patient required addressing the medial side of the elbow. Of the 34 patients who had at least 6 months follow-up, 25 only had the index procedure, while 9 patients required secondary surgeries. So for our results, we found that the early dislocation rate was 1 out of the 52 patients, so 2%. And this was a patient who had a direct fall onto the elbow, and intraoperatively was found that the LCL repair had failed. In the secondary surgery group, there was, again, 9 patients, and the most common indications for a secondary surgery was stiffness or NHO, as well as ulnar neuropathy. The most common procedure performed were excisions of HO, ulnar neurolysis, and synovectomy. So looking at our range of motion data, so in the group that only had the primary surgery, their flexion arc was about 110 degrees at their final follow-up, and supination pronation was 148 degrees. In the group that required secondary surgeries, before their secondary surgeries, their flexion arc was only 57 degrees, and their supination and pronation was only 55 degrees, which was statistically significantly less than the primary surgery only group. And after secondary surgery, their flexion arc was 96 degrees, and supination and pronation was 124 degrees, which is not statistically different than the primary surgery only group. In terms of stiffness, HO in particular, both groups had a high amounts of HO seen in a lot of their radiographs. In the primary surgery only group, this was about 75%, and in the groups that had secondary surgeries, all of them had HO. So the kind of overarching theme here is that with an algorithm emphasizing biomechanical principles, we found a low dislocation rate and good functional range of motion in the groups that only required index procedures, but that stiffness in HO was quite common. And the groups that eventually did have secondary procedures done, they were eventually able to achieve good range of motion and functional range of motion of their elbow. So the limitations of this study, it's a retrospective review, and we had a 35% loss of follow-up. And we also didn't have any kind of standard validated outcomes, such as a DASH score to help really quantify some of these quantify some of the disability in these patients. This is also a long period of collection. It's from 1995 to 2013. So there was some variability in terms of prosthetic designs and suture material used, but overall consistent techniques were used in reviewing the operative reports. So with regards to the dislocation rate, again, we had a low dislocation rate at 2%, and again, this is a result of direct trauma. And this is, again, consistent with the literature that's out there in some of the smaller studies. In terms of range of motion, we found that 75% could achieve at least a flexion arc of 110 degrees and supination and pronation of 148 degrees, which, again, is within what we think of as functional elbow range of motion. Again, this is consistent with a lot of the other studies, smaller studies that are out there. In terms of the secondary surgeries that were required, again, we found this to be about 25-26%, with HO and ulnar neuropathy being the most common. And that based on kind of what we saw intraoperatively, sometimes ulnar nerve transposition was required, but sometimes it wasn't. And so routine prophylactic ulnar nerve decompression we don't suggest as a standard thing to do. After secondary surgery, we again found that patients significantly improved their elbow range of motion, both in the flexion arc as well as the supination pronation arc. And again, there's some studies looking at synovectomy and how patients can achieve functional range of motion after synovectomy in a post-traumatic setting. But again, we suggest that secondary surgery must be tailored to the individual, their radiographs, and what they're trying to get back to doing. So those who do have decreased range of motion, 6 months or a year into their recovery, should be considered for secondary surgeries. HO continues to be a difficult problem. We don't recommend routine prophylaxis at this institution. Compliance is an issue, as well as it's sort of a difficult thing to predict who actually would benefit. Literature currently doesn't really have a whole lot of conclusive evidence saying whether HO prophylaxis would be beneficial in these kinds of settings. So overall, the conclusions of this project are a biomechanical approach to fixing terrible triad injuries can lead to functional results in the majority of patients, and in those with poor range of motion, secondary surgery can also restore a good functional range of motion. As a kind of take-home point for the residents in the room, when we're counseling these patients when they come into the emergency department and we're counseling them the kind of natural progression of this disease, we're not trying to necessarily give them a completely normal elbow, but we can hopefully expect that a functional elbow can be achieved. And then when we're seeing these patients back in clinic, if they're 6 months, 9 months into their treatment, they have really stiff elbows that aren't functional for them. Good functional range of motion can be attainable with some secondary surgeries. So again, I'd like to thank all my co-authors on this paper and all those who helped on this project. Thank you very much.
So if you had, you have 26% that you had secondary surgeries, and 26% of those had heterotopic ossification.
Was it and 21% of that 26%, or was it 21% overall had an ulnar neuropathy? So how many people had an ulnar neuropathy independent of heterotopic ossification?
So, and we looked, we couldn't study that in the primary group only because those ulnar neuropathy wasn't very well documented in those who had index procedures only. In those who had secondary surgeries, an indication for surgery in 7 out of the 9 patients was ulnar neuropathy. All of them had HO though.
So all of the patients that had an ulnar neuropathy that had heterotopic ossification, was the heterotopic ossification addressed also?
It was.
So I think that you might want to consider that the conclusion is that patients that have terrible triads with stiff elbows and have their heterotopic ossification removed, if you don't release their ulnar nerve, they're going to get worse. And so it may be that although it was listed as an ulnar neuropathy, which it may have been, it's actually a good practice to take any elbow that has minimal or a limited flexion extension and release the ulnar nerve if you're doing a procedure that's going to increase the flexion and extension. Because if you look at the stiff elbow literature, those people that don't actually get worse with that procedure.
Thank you. Yes?
Great job. You mentioned there's very little literature on this. It's also really difficult to follow the patients out in terms of getting follow-up. Are there any risk factors that you identify as far as outcome, whether it's radial head arthroplasty versus ORIF? Also, did the repair of the corneal have any effect on stiffness and range of motion?
So we ran some analysis on those, but those didn't have significance. Again, I think a lot of that's contributed to the fact that even though this is a large study for terrible triads, it's still only 36 patients with adequate follow-up. And again, the large majority had radial head arthroplasty. Only 12 out of the 52 had their radial head fixed. So I think this is sort of outside the scope of this study, but would be an interesting question.
And the corneal fixation didn't really have an effect on range of motion either.
Right.
Cohort.
So I think you're to be congratulated for a great study and great outcomes. And you tend to look at failures and try to figure out what you would do differently there. And I think the HOs would be expected, and you address the limitations. And you had one redislocation, which I don't think in the paper you mentioned that it was a subsequent fall. So I was wondering if you should have had one X fix, but it sounds like you shouldn't have. So I think the real strength of this paper is there's a number of points at which you could make decisions, and you could make the wrong decision. And it appears that this group never made the wrong decision. That if you decided to replace or fix the radial head, they went on and did well. If you decided to fix or how to fix the coronoid, they went on and did well. And then you assessed the stability, and then you did your lateral ligaments, and I guess occasionally you did the medial ligaments. So my question is a couple. One, will you relay to mortals who are treating these injuries how you made each of those decisions? I think it would be nice to know that. And I understand it said in your paper, you said if you could fix the radial head, and I felt you could, but some more descriptors there would be helpful for those of us who don't do this many. And then the one issue that struck me in the paper was you said that you accepted valgus instability. And I just was hoping you could expound a little bit upon how you assess stability in the OR. And I'm sure my elbow exam is not discrete enough to distinguish between valgus instability and potential early elbow dislocation instability. And if you could just expound on that a little bit more for me.
Sure, yeah. So to address the first part of your question, I think that was actually probably one of the more interesting things for me in terms of why to do this paper, and something that I thought was an interesting thing, because we treat this injury probably here more than most places do. It's a difficult surgery, and historically have had poor outcomes. And again, this protocol had sort of been developed based on some of the biomechanical papers that showed that this sort of algorithm led to biomechanical instability, and then how well does that translate to outcomes in patients, I think was kind of what we're hoping to get out of it, so that, if the mere mortal surgeon was trying to do this surgery, they could sort of rely on the biomechanical principles that fixing the coronoid, fixing or replacing the radial head, and then addressing the lateral ligaments would generally lead to good outcomes, as we've seen in the literature. And so that I think was sort of the underlying theme of the paper in terms of what we're hoping to communicate to fellow surgeons. In terms of valgus instability in the OR, this is one of those things that at the end of when you have all your fixation in place, you take it through a radiographic under fluoroscopic imaging, and you try and see whether you think that the elbow is unstable. And now, me being a resident and not having as much experience in this kind of surgery, certainly I think there's a lot of kind of clinical expertise that's required for that. But whether the elbow would dislocate, of course, is a big one. That's an automatic. I think you have to go and look at the medial side. And then whether, I think it relies a little bit on clinical judgment as to whether you think the instability is something that could be treated with splinting and rehabilitation versus a gross instability that would need to be addressed. And then to answer the last part of your question about fixing the radial head, that I think is starting to be described in literature further now in terms of the number of parts to a radial head fracture and what parts of the radial head are involved as to whether a replacement or fixation is done and whether that leads to good or poor outcomes. I think radial head resection is now sort of really fallen by the wayside, as that's sort of proven definitively in the literature as to have poorer outcomes. But then a lot of it is, again, clinical judgment. And having, again, been part of a few of these cases, you look at the radial head, you try and see how many pieces it's in and how comminuted it is, and what the realistic expectation of the competency of the cartilage, and then getting it back together in a congruent joint is going to be. And if it's not going to be there, then you proceed to radial head arthroplasty.
So are David and Daphne here? Either of them? So as far as the valgus instability in that series of cases, if it didn't dislocate, that was fine. That was the criteria. They're actually pretty black and white. If it didn't dislocate with valgus strain, they left the medial collateral ligament in alone. And then you're right about the number of parts, but it was, the criteria was if they were able to reconstruct the radial head and the articular surface was in the safe zone, was not touched or penetrated by metal, that was a fixable radial head. And so that was the number one criteria. Then beyond that, it was if it was more than 2 parts, that was an immediate arthroplasty in those cases. That's a great paper. Thank you.
Thank you.
Next up is Sean Halliman. He will be speaking on the specific biologic influence on fracture healing.
All right, good morning. Thank you, everyone, for showing up today. Thank you, Dr. Zura. If you hadn't gotten your mid-morning nap in, now might be a good time to look at the back of your eyelids. So my name is Sean Halliman. I'll be speaking on ESET histone methyltransferase and its role in fracture healing. My mentor on this was Liu Yang, who does a great job at the VA, and there are no major disclosures for this study. And I think in order to move forward with our portion of the study, it's important to go back to medical school a little bit and talk about DNA and chromosomes and epigenetics and what that all means. So epigenetics is the control of gene expression that's not directly associated with a DNA sequence. And so if we take a look at this, our DNA, when it gets organized into a chromosome, gets wrapped around histone molecules. That creates a nucleosome. Bunch of nucleosomes together creates chromatin, which winds into a chromosome, and that's how we pass on our genetic information to our offspring. ESET, and we'll leave it at that, it's got a much longer name, is a histone methyltransferase that is responsible for methylation of the third histone. And if you look down at the bottom right corner, it's kind of an example. What would happen is it would methylate a histone tail, and that would either unwind or wind that portion of a DNA sequence, allowing access for transcription factors to transcribe the gene. And particular interest for ESET is that it has a specific role with RUNX2, which is important for differentiation of mesenchymal cells into mature osteoblasts and chondroblasts. We know that ESET is ubiquitous in all cells, and that a pure knockout of ESET in a mouse would be lethal during embryogenesis. What's very interesting is Dr. Chansky and Dr. Yang's lab created a specific knockout of ESET in mesenchymal cell lines only. And what they found with those mice is that they demonstrated severe dysplasia. You can see in the imaging here the wild-type mouse in each box category next to its knockout mouse counterpart. At the same age time points as the knockout mouse is significantly smaller, and the bones have significantly more dysplasia. And with 3D reconstruction of a micro CT scan, you can again see a striking difference between the two. So then, if these mice have a significant skeletal dysplasia, then ESET must play a critical role in endochondral bone formation. And so they took H&E stains of the growth plates, and on the left you can see the wild type mice, and they had a nicely organized standard growth plate, and on the right a very disorganized growth plate and early closure of the physis. And they noticed that this shared a lot of similarities with Indian hedgehog gene knockout mice, in that there were hypertrophic chondrocytes that were ectopic, their early closure of the physis, and the trabecula of the bone were misshapen. So one of the first steps was to identify whether ESET played a role in Indian hedgehog gene expression, which it did. So if you look on the top portion, you can see the wild-type mice, and I think more poignantly, you can see over on this side the anti-Indian hedgehog staining, that on the bottom of the knockout mice, there's almost no expression of Indian hedgehog, where in the normal mice, there's normal expression. But what was the role with ESET in mesenchymal cell differentiation? And the thought was that it was also critical for that portion. So very similarly, they looked at the growth plates of the mice and stained for anti-osteocalcin. Quick shout out to the chiefs for boards. Osteocalcin, most abundant non-collagenous protein in bone. Also a marker of mature osteoblasts. So you can see here the red in the mature osteoblasts. Pretty significant in a normal mouse, and then down here with the ESET knockout mice, not as much osteocalcin, so no mature osteoblast. And then if we're talking about bone remodeling and formation, we need to address osteoclasts, and they, as you would expect, if a knockout mouse has mesenchymal cell line a knockout only, it should not affect osteoclasts, which are from a monocyte lineage, and they also proved that in their previous studies. So that leads us to this study. How can epigenetic regulation affect fracture healing, and more specifically, how does the loss of ESET histone methyltransferase affect fracture healing? And our hypothesis, as you might expect, is that ESET in all mice will have a defective callus formation, decreased bone remodeling, and delayed healing of a fracture. So we identified 12 ESET knockout mice and matched them with 12 wild-type littermates to be used as controls. We waited for the age of maturity, which was 2 months in these mice, and then took them to our modified operating room. You can see here a micro CT scan of corticotomy sites we used to simulate fracture, which was a kind of a tough decision to come at, because there are multiple models for fractures in mouse models. And one of them are closed fractures. The downside of that is they're not mobile, and so you don't get to see what stress loading does. The other is doing an open osteotomy and then stabilizing the fracture somehow, but in a 2-month-old mouse, stabilizing a tibia in a normal mouse is significantly challenging. Doing it in a dysplastic tibia was impossible. So we used a model where we created just a corticotomy site, and on the normal sized mice, we used a 1 millimeter drill, and on the small tibias from the dysplastic mice, we used a 0.6 millimeter drill. They were given 72 hours of analgesia and then returned to cage for unrestricted activity, and they were monitored for any signs of decreased baseline activity. And then 4 mice from each group were randomly selected to be sacrificed at 3, 8, and 49 days postoperatively. The corticotomy sites were compared with H&E staining and micro CT scan. And we saw some pretty interesting results. So these are the H&E stains from postoperative day 8. On the left, you can see the wild type animal, and on the right, the ESET knockout mice. So on the left, you can see the corticotomy site is full of woven bone already. It's got a nice fracture callus on the outside. It's healing also intramembranously from the inside. And then on the right, with the knockout mice, you can see an amorphous fibrous cellular tissue that does not have any structure or any woven bone yet. On postoperative day 49, you can see the corticotomy site on the wild type mouse on the left has been completely healed and is undergoing some remodeling. And on the right, you can see that the fracture gap is actually not yet healed all the way. You don't see any evidence of any fracture callus in those mice. And then if you look at the micro CT scan, it's just another verification. You can see on the anterior cortex of the tibia, there's significant remodeling going on in the mouse tibia, whereas on the knockout mouse, though a little bit out of phase from where the osteotomy was, there's no evidence of any remodeling occurring. So in discussion, the ESET histone methyltransferase regulates RUNX2, we know that. And we know that it actually inhibits the production of RUNX2. So if you get rid of ESET, there's an overabundance of RUNX2. And that is important because if you take away that regulation, then you don't get the standard osteoblast or chondroblast differentiation than you would in normal mesenchymal cell maturation. And therefore, proper bone formation is inhibited and thus fracture healing is delayed. I think there are obviously very significant limitations to the study. It's very qualitative data. There's no quantitative data associated with it. The knockout mice that we used had severe dysplasia, so they not only had abnormal bones, but they probably had abnormal bone biology also, so fracture healing was more challenging. The tibias were extremely small, making standardization of the size and location of the corticotomies pretty challenging. And those knockout mice were less mobile. The dysplastic mice just didn't get around enough, so maybe there was a role in decreased amount of strain across the fracture site, limiting fracture healing. And then lastly, a basic H&E stain is nice to show that there was a fracture callus that formed at the corticotomy site and then eventually it healed in the wild type mice and did not. But it doesn't tell us what types of cells are showing up at the fracture site. It doesn't tell us what role angiogenesis and vascularization of the fracture site plays in the fracture healing. So I think in the future, one of the major steps will be to create a conditional mouse that's allowed to mature as a normal mouse and then use a drug-induced knockout of ESET and then create a fracture and see what role osteoblast differentiation in ESET has with that in fracture healing. We would also like to start staining for different mature mesenchymal cells at the level of the fracture site to see if it's a defect in only osteoblasts or if it's a combination of all things that RUNX2 is involved in, including chondroblasts and fibroblasts. And then lastly, some sort of clinical application would be important. This is where we'd want to go with this. If you can increase the expression of ESET, would you be able to improve fracture healing, or would you disrupt that delicate balance of regulation of RUNX2 again and disrupt osteoblast maturation and bone healing? Thank you.
Sean, I will just say that was a masterful presentation of a really difficult topic, so thank you. It was great.
I don't claim to know half as much as Dr. Yang about all that, so I appreciate it.
I think that was is a great presentation and a great topic. I wish you hadn't put my main thought on this in your future thoughts, but I think genetic treatment of diseases or of bone healing or non-unions or poor healing is coming, and I'm not sure that I see that for this, because I think you pointed it out exactly, that this may just be a sort of a regulation level, and that more may not be better. But I think that would be really interesting to see, that if you can have somebody who's not healing, then provide it. But I agree that it may not be there. I wanted to ask you a little bit about your model, and I share the difficulties, and I understand that. And it's hard to be too critical of your model, because you did have a pretty robust callus that looked like fracture callus in the wild type. But I was curious if you think the mechanics of fracture and corticotomy really are the same. And I wonder if you had the instability associated with fracture and some of those forces that we see in a more true unstable situation, if maybe the magnitude could change. I would like to see the knockout mouse with a more true fracture pattern and see if they make some callus. And then, so some just comments on your model. And then the second thing, from my eye, and it's a bad one, it looked to me in your sacrificed study mouse that the gap was smaller. And do you think it was healing primarily? And that bone looked pretty normal, it just wasn't healing by callus. So is this really a lack of callus formation rather than a lack of healing?
Yeah, those are excellent points. I'll go back to that slide that you were talking about, because I had some of the same thoughts. I think if you look at the corticotomy site, this is again 49 days afterwards, so 7 weeks after the fracture. It is narrowed significantly from where it was before. And if you really look at the magnification, it does look like primary bone healing is occurring, that new osteoblasts are making their way to the edge of the bone and laying down osteoid, which is being calcified, which I think is what we thought was happening, and that they just didn't have robust fracture callus response. And that kind of ties into what you were saying about the fracture model, in that a corticotomy doesn't really represent a fracture. It's not mobile, and you would think that more primary bone healing would occur. And we did use a smaller hole with the knockout mouse, so maybe it was such a small hole that there wasn't as much stress around it, which caused it to heal with primary bone healing. And that's why I think it would be very important to have a conditional knockout mouse fracture model instead of using a dysplastic tibia, so you can standardize whatever fracture method you're using.
Really nice talk, Sean. You focus at the beginning of the talk on approaching this from ESET's role in altering osteoblast differentiation.
Yep.
One of the early stages of fracture healing that leads to non-union is impaired vascularization. Do you have any feel for whether this pathway might be influencing that in somehow?
I'm not entirely sure on the role of angiogenesis and vascularization of the corticotomy site. It did appear that there was an attempt at ingrowth of some cells into the fracture site of the wild type mice, indicating that there was probably some sort of blood supply or hematoma. And I think what we could probably do is either stain for red blood cells or factors within a hematoma to see if that's the case. And it's just not the differentiation of a mesenchymal cell versus the supply of the mesenchymal cell to the location of the fracture site. Thank you.
Next presentation will be Dr. Emily Harnden, who will be talking about weight bearing with fracture fixation of the ankle.
All right, so I'm going to be talking about a study I did with Dr. Firuzabadi and Dr. Krieg, looking at protocol of immediate weight bearing after ankle fracture fixation. I don't have any disclosures. A little bit of background. Ankle fractures are very common, as we all know. We often treat unstable fractures with open reduction. Goals of our treatment are typically to maximize function and minimize the period of convalescence and immobility. We also want to minimize complications at the same time. The postoperative protocol for ankle fractures is very controversial for many factors in regards to postoperative range of motion, whether we keep our patients non-weight bearing and how long that period is, or we allow them to weight bear immediately, and if we do allow them to weight bear, what do we put them in? And types of immobilization such as a cast, cam boot, or any, or lack thereof, I should say. There was a recent survey out of OTA and the AOFAS members that revealed significant variation in the period of postoperative non-weight bearing, and they found the average period was about 4 to 5 weeks. So the purpose of our study was to determine if a certain subset of patients with surgically treated ankle fractures can weight bear as tolerated immediately following surgery in a cam walker boot. And our hypothesis was that this specific subset of patients can be allowed to weight bear immediately after surgery without compromising fixation. So this was a retrospective review of trauma data gathered here at Harborview. All operative ankle fractures treated by the senior author over a 5-year period were identified, and the patients we included were any patient allowed to immediately weight bear as tolerated, and we excluded anyone that was made non-weight bearing, and this was determined by the senior author. So this included any patient with a syndesmotic injury, any polytrauma patient, if there's a fracture dislocation that required reduction in the emergency department, or any articular injury. And additionally, we excluded patients with any soft tissue concerns with or without bone loss. And lastly, we excluded anyone that didn't have any follow-up beyond 12 weeks. Surgical protocol, the fibula was fixed, the medial malleolus was fixed as well, and the posterior malleolus was fixed if necessary. Skin was closed with 3/0 nylon. Postoperatively, all patients were instructed to immediately weight bear as tolerated in a cam walker boot. This was kept on for 2 weeks. Clinic follow-up was performed at 2 weeks, in which the suture was removed, and patients were instructed to wear the boot for an additional 2 to 4 weeks and wean as tolerated into a normal shoe. At 6 weeks, patients were instructed to discontinue the boot completely if they hadn't already done so themselves. And x-rays were obtained at 6, 12, 24, and 1 year. So we identified 136 surgically treated fractures. 33 were allowed to immediately weight bear. 7 were excluded due to lack of follow-up, and that left us with 26 patients in our study group. Our patient group, there were majority males, 20 males, 6 females. There were 15 smokers in our group. 8 of our patients were diabetics. There were a variety of mechanisms, but most were low mechanism falls. And AO fracture classification of these fractures, the majority were type 44B, which is a transsyndesmotic fibular fracture. The lateral malleolus was fixed in all patients. Most were fixed with a 1/3 tubular plate. Pre-contoured posterolateral plate and IM nail were used in the remainder. The medial malleolus was fixed in 11. Most were fixed with screws. And the posterior malleolus was fixed in 5 patients, and again, most were fixed with a few screws. Clinically, we had average follow-up of 140 days. At 2 weeks, 2 patients were identified as having peri-incisional erythema, which resolved with the course of PO antibiotics. At 6 weeks, 20 patients were wearing normal shoes, and 6 had continued to wear the cam boot. And at final follow-up, 3 patients were identified as having ankle stiffness. 1 patient had perineal tendon subluxation that was treated with physical therapy, and 1 patient had symptomatic hardware that required surgical removal. Radiographic results, intraoperatively, 25 patients were noted to have an anatomic reduction. 1 patient was known to have an asymmetric joint on immediate postoperative imaging. In 6 weeks, the 25 patients with anatomic reduction in surgery had no loss of reduction. There was 1 loss of reduction that's seen here, and that was identified as the same patient that had an asymmetric joint in surgery. And reviewing that patient's imaging, he had a syndesmotic injury. So that patient required a surgical revision. At last follow-up, including this patient with the revision, there was no loss of reduction or signs of hardware failure. So discussion in the literature, early motion, immediate weight bearing in a cast, or early weight bearing has been shown to have similar, even improved outcomes versus a period of non-weight bearing. Functional bracing versus a below-knee cast is associated with earlier return to work and improved functional outcome scores. Immediate weight bearing in a cast has equivalent clinical and radiographic graphic outcomes versus late weight bearing in a cast, and a study looking at functional early weight bearing at 3 weeks in an air cast versus a 6-week period of non-weight bearing allowed earlier full weight bearing in the early group and no differences in clinical and radiographic outcomes. There's one study that's looked at immediate weight bearing like ours without a below knee cast. This was a retrospective review of immediate weight bearing versus non-weight bearing in a cast for 6 weeks, and those in the immediate weight bearing group had earlier return to work and no difference in clinical outcomes versus the non-weight bearing group. Our studies suggest that immediate weight bearing in a subset of patients is a safe alternative to a period of protected weight bearing. There are clearly many limitations to this study. It's a small retrospective case series. We have no control group. The subset of patients and who was made non-weight bearing or weight bearing was determined by one individual, and that same individual was the person performing all of the surgeries as well. We didn't have any range of motion data recorded, and we were not able to determine what the actual timing of weight bearing for these patients were and how they complied with our instructions. They were simply instructed and said and allowed to weight bear as tolerated, but whether they actually did that, we don't know. So in the future, well-designed, controlled, prospective randomized studies are necessary to answer this question. There are a few that have been done or are in progress. One study out of Canada is a randomized controlled trial of unstable ankle fractures treated with open reduction internal fixation. They had one group that was allowed to weight bear early and mobilize at 2 weeks, and another group kept non-weight bearing and mobilized for 6. And they found that weight bearing at 2 weeks resulted in improved function and outcome in the early postoperative period without a difference in return to work or the complication rate in either group. And again, this study allowed their patients to weight bear at 2 weeks, not immediately after surgery. There's another study out of the Netherlands that's ongoing right now. It's a prospective randomized multi-center clinical trial to compare 3 groups, an unprotected weight-bearing group immediately after surgery, one that is unprotected but made non-weight-bearing, and then one that is a protected weight-bearing group. And they have 1-year outcomes are expected next year. So in conclusion, immediate weight bearing as tolerated after fixation of unstable ankle fractures can be safe, a safe alternative to protected weight bearing in a subset of patients, and that's those that have an intact syndesmosis, an isolated closed injury, and no articular injury. That has the potential to allow better mobility, earlier return to work, and a shorter period of disability for these patients. And in the future, it's important that we look at this with better designed studies and randomized controlled trials to better answer this question. Thank you.
In the subset of patients that you looked at, did you, you must have looked at their age. I'm not sure I missed if there was a distinction in the age of the patients that you evaluated. And in those patients that you included in your study group, did you look at the operative notes? Were there comments about the quality of the bone? Was there comminution? And whether or not a kind of intraoperative anatomical reduction was achieved versus radiographically looking like it had an anatomic reduction. Sometimes there could be a difference.
Yeah, we didn't, in the operative notes, we didn't look at the commentary on quality of bone or commentary about the actual reduction in surgery, just radiographically. And then age, I didn't put it in here, but age ranged from late teens to early 80s.
I think this is a really great study, and I want to congratulate on it. I think anytime you challenge dogma, it's exciting. And I also want to compliment you on your cojones, because I don't know that I would have been willing to include some of these patients in that early weight-bearing group, in particularly the diabetic patients. That's really challenging dogma, and it's exciting to see some of this new data. I'm a little bit confused by your inclusion, exclusion, and maybe I just don't fully understand it. And I think this was a retrospective study over time, and I think some practices have changed, so I was curious your thought. In particular, the posterior malleolus is confusing me in this situation some, because I would consider that going into the plafond, and in my mind, that's at least a proxy for a syndesmotic injury. And we're fixing more and more of those now, but what I think I'm doing is restoring the syndesmosis without putting a screw or a tightrope or whatever. So I'm curious your thoughts about that, and because you said some of your patients did have posterolateral fractures that were walked early. And the second thing, and I know your institution is published on this, is do you have any anxiety about the medial fixation, and have you converted to bicortical screws, especially if you're thinking of walking them earlier? Does that give you more comfort, or do you think there's no need to do that?
So for the posterior malleolus fractures, I think the patients that were allowed to weight bear with those fractures were those that had, on testing the syndesmosis after fixation of the posterior malleolus only, was stable. If they were still gapping and syndesmotic screws were placed across the syndesmosis, those patients were not allowed to weight bear. And that was determined by the senior surgeon. And then for the malleolus, just in my experience working with everyone here, it seems to be variable if patients are treated with unicortical medial malleolar screws or bicortical, and I'm not sure if that factored into this particular surgeon's decision-making to letting them weight bear or not, but most of the medial malleolus fractures treated with this, by this surgeon, were unicortical. I don't know if that answers your question, but.
So you had an exclusion. You had an exclusion of fracture dislocations, and then the image you showed there was looked like the injury films where the talus was perfectly reduced under the plafond. Do you have a sense, since there wasn't that large of a number of patients, how much initial displacement, how much subluxation there was on the initial films, or were they all similar to the example you gave?
Some had a few millimeters of subluxation, but no patient that had a frank dislocation that with the talus out from underneath the plafond were allowed to weight bear after surgery. So some had some, I didn't show a picture of it, but some had some mild subluxation, but no significant displacement. So if any patient that required a sedated or a analgesia in the ER for a reduction were not allowed to weight bear after surgery. Thank you.
All right, next we were actually going to take about a 15-minute break, so we will reconvene after that for Dr. Alvine's talk. Thanks.
Oh, yeah. So the red button there will do laser.
Super.
And then if you hit to the right, advance to the sides.
Oh, what's that now?
So if you hit
This
to the right.
advances the,
Yeah. So if you.
this advances and goes back. Huh?
Yep.
Well, I should be able to figure that out.
Go, you can go hit the button if you want. But yeah.
Sounds good.
Perfect.
All right.
And I'll kick on your mic here in a minute.
We'll figure it out, huh? One, two, 1, 2, 1, 2, 1, 2. I'm going to change it in the back. 1, 2, 1, 2. Move it over here.
haven't written that one for you. You can read that.
That's not rude. That's authentic. No, I think he's gonna be surprised. That's pretty sweet. That's all just me.
Designs for vision, and we always send out emails.
Oh, no, I do that with my brother did watching. Who do you do this from? Who do you do this from, Mary? No, what I do is all the kind of.
This year I had some Peter on board.
One of the like one time I was on call, our case got canceled, and I was running outside of the children's. Because the treadmill didn't work. Oh yeah, that's a good story. So the treadmill doesn't work in children's. There's a number of these problems. So I called. Same thing. Yeah, it's the workout. So I called the leader and I said, hey, the treadmill's broken. And they said, oh yeah, we know that. We've had like 6 people call us. I said, they should, like, oh no, someone needs to see it. So they go, how do you do that? Oh, it's just on your shoulder. Yes, fix it. And it's like, I have no idea. This is your job. You're listed as the person to call. Yeah. You're listed as the person to call. I put a door on. Hey, you put it on. So we're going to know it's. I can't tell the story. She's like one of those other hospital things where people are just like, it's not my job. Treadmill children's. So I call them just like randomly told me that I was like, there's a gym on the 5th floor. Yeah, so if you walk down to the mountain, you walk down the stairs and you go to the 5th floor and someone just goes like, like it's really straight down the hallway, just right to the left. You step that way, there's 2 offerings. And then the gym has a little bit full treadmill. Yeah, so I did that for a couple of weeks. It was really nice. I thought it was that's what makes sense to me. U number is 370.
Oh, it's really, that's where it's going. That's, I'm not sure yet. I imagine it's probably something extra hour, since there's a trend. Just walk down there. Sorry, it's on Jameson for you walk 6 blocks there. Yeah. Six stops to get through. Oh, that's what yeah.
Either way, or tab, or whatever you want. I'll talk to, I'm stuck at board is the problem.
Tomorrow?
Yeah. Otherwise I would do it myself, and I think I have to be there at that
Yes,
time.
I did.
Question for you.
Yeah.
Do you want cheese in the lunch? It's totally, they, for me, it's totally pure. And if you want to join, or you can. Trust me, it's not. Or would that be okay, or?
Well, it'd be great.
Okay.
It would be great, but only if
That's what I'm, trust me.
Yeah, that would be perfectly fine.
Okay. I'm not gonna go to the meeting because. Uh-oh. It's really not funny other than talking about what I. Look, I'll leave my phone on the floor. I'll talk to them.
Yeah. But you make sure that's clear.
Yeah, I got it. How you guys doing?
Good.
No?
Yeah.
This, downtown. Okay, so how long are they gonna do?
Yes.
I've been, I asked her, she goes, no, we gotta come over. I'm like, you got 25 already. I'm like, yeah. Okay. What, your classmate, buddy?
Yeah, sorry. You already talked.
Yeah, thank you. Sorry, I was on call here last night, so I couldn't make it to the.
Were you busy?
Yeah, I got out of here about 5 minutes. stuff, and I was like, I'll have fun tonight. So thanks for coming.
Yeah, no, I
really
appreciate
appreciate you guys being here and talking with us.
Oh, thank you.
No, it was really good to hear, and I think we have like we have every week about the conference, but not union, so it's really good to see that.
Yeah. Is your family all in town?
Yeah, I'm from Vancouver, Canada, so they're just driving down today. So they'll be here. Yep.
You gonna get back to Canada?
Probably not. We'll see. My wife's from suburb of Seattle. She's a physician as well, and so there's a lot of complicating factors to going back to Canada. Believe it or not, they're very, basically zero jobs. So most of the
Without 2 fellowships?
Yeah, 2, 3 fellows. A lot of the fellows, like, we want us to come and they do, they're in a third fellowship or something like that, and they're still looking for jobs, and then one opens up, everyone will apply to the job, and so, my sister is also a physician and just got kind of lucky in an ophthalmology practice in Vancouver and with UBC. But it seems like she did locums for a year up there before she found that stuff.
Wow.
She's very well trained down here.
What are you gonna do?
Foot and ankle.
Where?
Yeah, at HSS.
Oh, cool,
Yeah,
great.
so I'm excited to go there.
And your wife is what your position?
Pediatric nephrology.
Is she done?
She's in, so she's in her second year for fellowship, which is 3 years long, so we'll be apart for a year, but then we finish the school time.
Right.
So,
Then you go wherever.
oh yeah, we're hoping to be here in the Northwest just because.
So do you have to work on a visa or are you?
So, up until a month ago, since I left Vancouver after high school, so I did my college, med school. I got married last August.
Yeah, I told them to come in already. Yeah, I think they're mobilizing. Thanks.
Not that you started off in patient. So when you become an American citizen, you have to keep your now all other citizenships. And then then you become a patient citizen again. But if you're a U.S. citizen, we'll figure it out. Sure. No, thanks.
All right, as people start to make their way in, I have the pleasure of introducing our next speaker, Dr. Alvine, who's decided to join us today with his family. Dr. Alvine was born in South Dakota and started his schooling there. He then, after completing 2 years of schooling of pre-medical work, moved to the University of Washington, where he finished his MD degree. He then spent 3 years in the Naval Forces and became a lieutenant, after which he joined Dr. Wagner in the UW Orthopedic Residency Program. He graduated here in 1972 and then returned back to the homeland to work in South Dakota. He has had many accomplishments, 2 of which I'll go over. He has helped to pioneer and research and innovate the total ankle system agility. And the other is, back in his practice, there were multiple lawsuits occurring with regards to the ulnar neuropathy that can sometimes occur after surgery. So he took it upon himself to do a prospective study which included approximately 6,000 patients, of which 17 of those developed ulnar neuropathy postoperatively, and determined that it was in fact not the surgeon's fault, and it happened to do with subclinical cubital tunnel syndrome prior to the surgery, and this helped to reduce the litigations and make this now a non-payout for such litigation. He now joins us, and I'd like to introduce Dr. Alvine to give his talk.
Thank you very much for the introduction. It's really hard for me to appreciate the fact that I was sitting in your spot 50 years ago. I was sitting there, I said, I can't believe this, and I'm back here 50 years later, but that's the case. And just to prove that I was here, oh, let me back up, Lori. Just to prove I was here, you may not recognize me, but there I am. Does this work? So here we are. Dr. Clausen was our chairman at the time, and I'm sad to say he passed away about, I think, 3 or 4 months ago. So, in any event, that was our class then, and you can see it's grown substantially since that time. It's exciting for me to be here at a research day, in particular, since I have always had kind of a desire to find out the answer to some of these problems. And I see we're still discussing many of the issues we were discussing 50 years ago. So we definitely made progress. But I liken in research to trying to fix an old car such as this. You have an hypothesis. You don't have to prove the hypothesis, but you have an hypothesis, and you hope that when you get all done collecting bits and pieces of information from the world literature that you can make some sense out of it. You may end up with nothing, which is junk, or you may end up with something that's valuable. And it may be truly contributory to some of the problems that we face. Anyway, this was a car that I inherited after a tragic automobile accident with one of my friends. His wife wanted me to put this back together again after he had taken it all apart. But after some work, I got it put back together again, and it's been a fun car to drive. So once in a while, your research will produce something valuable, and I think so. When I listen to these talks here this morning, you know, there's a glimmer of hope in all of them. When you think about total ankles, you want to think of this slide. You want to proceed with caution. There are many pitfalls in the world of total ankle replacements. And when I first got interested in total ankles in 1972, by the way, when I went into practice, I right away started doing all kinds of surgery that I wasn't trained to do. Total hips, total knees, total ankles, pedicle screw fixation and back. All this was totally new to me. We hadn't done no total joints at the University of Washington when I went into practice. So a whole host of total ankle replacements were introduced in the early 70s. From 72 to 78, there were 23 designs already on the market, been used. Most of them had been withdrawn from the market. It grew up to 32 designs. The agility ankle, hit the wrong button here. The agility ankle is in the two-component, am I hitting the right button or something here? There we go. Two-component list down here. When I first started practice, we did a number of the earlier ones in the constrained group, the male ankle, over non-constrained Smith, in the three-component process, the LCS. This one failed very quickly. As you can see, the star is still available. In the event, just to quickly go back, and review some of the early results. This is just an example of a totally constrained, that's an Oregon ankle. It had sidewalls. There was no actual rotation allowed in the joint. But you can glean from this that in the younger person, they had a higher failure rate. They're less than 57 years, but they were over 57 years, the failure rate was less. The Oregon ankle, in 2 to 7 years, 50% were good, 90% rheumatoid arthritis, though you had 90% good. So there's an indication that maybe in rheumatoid patients, possibly there's less demand, who knows. But there's another positive point there. The conaxial ankle Beck-Steffi, I'm sure Dr. Wagner recognizes Steffi's name with the pedicle screw fixation. He had an ankle, and within 10 years, 90% were loose. Mar Freeman was the first one to work on trying to put sidewalls on ankle. And I've been a firm believer from day one that you need to somehow stabilize the medial lateral forces in an ankle joint, which have been estimated around 2.5 times your body weight. So I've been convinced from day one that some sort of medial lateral stability was necessary. But he was fraught with many of the problems that we see with ankles today, and that's skin problems. And they can be quite a challenge. The multi-axial joints, St. Elmo Newton III from Seattle introduced the joint. He had an incongruous polyethylene, and that failed rather quickly. Smith et al. With the totally non-constrained joints, just a slip-in bearing, and you can see that within a couple of years, the 48% were good, poor were 52% already. So, well, a totally non-constrained joint didn't start out very well. Schultz in '87 was the first one to use a porous-coated material on a total joint. You got the New Jersey. I used many of those. They fell apart very quickly. Then Kofit introduced, or at least made popular, the star ankle. And this is just one of his earlier studies. There are many more since then, but that's still available today. Improper problems that you'll face with total ankles include skin, which I mentioned can be very challenging, especially if you get a plastic surgeon involved and he opens the wound up, wants to rotate a flap. If he exposes the joint, as total joint surgeons know, it's probably the end. But you have to have some way of accurately positioning the joint. You have to have multiple sizes to fit the joint. The cementing techniques early on were more of a problem. Now you're still required in most joints to use a dab of cement by the FDA, although the FDA, at least the word we got towards the end, was that it was at the surgeon's discretion. You must be able to address instability, you have progressive aseptic loosening to deal with, and subsidence. To put in a successful implant, I looked at 4 different areas. You got to pick the right patient. That means age, occupation, disease entity, whether it be rheumatoid arthritis, whether it be post-fracture, what have you. You got to look at the implant. Is it capable of handling what you want it to do? And do you have all the parts available and all the various bearings and so forth? Instrumentation is also, I feel, very important, that the joint has to go in precisely and take a lot of the guesswork out of it, so you can do this operation in an hour. You can go in, put your distractor on, put your alignment setup on, put the implant in, and do it reproducibly in a reproducible manner. The surgeon, I think, is probably the most important. I think you have to be married to this patient. In the early stages of this whole thing, legal-wise, I think you have to make sure that you explain thoroughly to your patient that you're doing something here that may lead to litigation, especially if they end up with an infection, skin loss, there's all kinds of problems. But you have to be willing to learn the procedure well and be willing to accept and care for complications. Just quickly, some of the anatomy. As you know, the ankle is 23 degrees externally rotated. You have 15 degrees, 15% weight bearing through the fibula. The lateral trabecular bone is much weaker than medial. Surface area 12 square centimeters, and the subtalar joint is important in the overall picture of things. The agility implant does allow a functional range of motion. It's an old study from the Mayo Clinic. You have 30 degrees average, 10 degrees of extension, 14 degrees of plantar flexion. You have 11 degrees of axial rotation, but only 5 of that is in the ankle. And the agility ankle does allow that amount of rotation. The joint is semi-constrained, minimal bone, and you have 6 sizes. The material that's used to cover the implant, as probably most of you know, was developed in the early 70s in Toronto. Total Shoulder, 1975, was the first one to use the porous coating. Fiber mesh plasma spray and sintered beads. The agility ankle lands right in here, 150 micra. Cameron all found that within 3 or 4 weeks you get bony ingrowth with the smaller size. If you can bridge a larger gap if you get up, if you hold it longer, and you can bridge a 1.5 millimeter gap 4 weeks, and you can bridge a larger gap with rigid fixation. But sintered beads is kind of where the agility ankle settled in. Polyethylene also has to be looked at carefully. In other words, you have to keep the contact stress at any point in the joint below 1,400 newtons per centimeter. And this was constant use of that joint. They took the agility ankle and they cycled it millions of times in the lab. And you have to keep it below that. It can tolerate 35, almost 3 times that amount of stress on an intermittent basis, such as climbing, descending stairs, and so forth. You must keep it congruous if you can. An incongruous joint allows for rapid wear of the poly, and the convex poly wears out 2.5 times faster than concave. Implant metallurgy was also another struggle we had to go through. We started out with titanium. It was brittle, inflammatory. It was switched to cobalt chrome, and it's been cobalt chrome ever since. Just to quickly go over the evolution of the joint, introduced in 84, 87, because of some base plate fractures, it was thickened. In 97, this posterior part of the joint was augmented. We used to use the old, what's called a flat back tibial component, but it crushed in posteriorly, so that was addressed. The study that was done at the University of Iowa includes all of these earlier ones as well, but I'll go over that in a minute. In 98, 6 sizes were introduced. In 2002, the tailor component was addressed. Fin was shortened. The overall size of each one of the tailor components was widened or enlarged 18%, and a stem tailor component to simultaneously fuse. The subtalar joint was also introduced. In 2003, a total tailor was developed or designed. And then in 2006, it was called the LP version, which is a low profile. And it allowed much wider base and less tendency for impingement. Here's just an example. This is the early tailor component, and then the 18% widened, and what we called the revisional component. And Dr. St. and Dr. Hansen, my son, I'm sure they're familiar with all of these. This is the final design. It was called the LP version. You can see it has wings on it for maximum coverage of the cut surface of the dome of the talus. There's the end view of it. Poly can be changed by going in and snapping it out right here. Pop the poly out and you can put in a new poly, in which really shouldn't take very long if you get adequately distracted. So instrumentation, accurate alignment, correct size, ease of insertion, anatomic and functional ligament tension, and that all relates to use of the external fixator. I don't have a picture of that, but external fixator was something I used on virtually every ankle that I put in. This just templates the size of ankle you're going to use, shows the instrument tray, the various sizes that you're going to pick, both for the talar and the tibial side, shows the alignment jig. This is the overall gross alignment here for lengthening the cutting jig. And then this here allows for the moving it away from the tibia or closer. And then there's a fine adjustment here for moving the cutting block further down or more proximal in the joint. This is a close-up view of the cutting block. You pin it here or here, and you just cut along and cut it out. You have to be careful, of course, with the posterior structures, posterior tibial tendon, posterior tibial artery. To my knowledge, no one's ever gotten the artery. This is the bone that's removed. You want to remove the lateral cortex of the tibia and the medial cortex of the fibula, since the lateral aspect of the tibia is quite soft. This shows the cutting jig used to make the slot on the talar side. Here it is in place, getting ready to make that slot. Here's the implant in place. Lateral view, you want the front of the tibial component to line up with the anterior cortex of the tibia. Same is true in back. Weight bearing, or we start range of motion in 1 or 2 days. Hospital, a lot of them are done as outpatients now. In 6 weeks, usually full weight bearing. You go slow with rheumatoids, non-compliant patients, larger individuals with smaller sizes. Some gals have real small ankle, and you have to be kind of careful, especially if their bone is soft. If they're rheumatoid, you have to proceed slow. Split 2 weeks if you have ligament reconstruction, heel cord lengthenings, linear fibular fractures. There you can proceed usually without any problem. This is one 11 years post-op. This is what you look for. You look for bony ingrowth, for the striations coming off of the tibial spine and along the surface of the tibial component. This gal had already a fused subtalar joint, and as you can readily appreciate, she has a bad talar-navicular joint and was facing a pan-talar fusion when we did this. And the last I saw her was about 11 years post-op, and she was doing fine. This is a patient, a younger gal that lost her talus in a horse riding accident. She woke up next to a tree with her talus sitting next to her, and came in and wanted to know if we could do anything for her. Designed a total talus. The only thing that went wrong with that operation was they put the stem too far lateral on the base of the tibial component, but it still stayed in bone, and she's now, I just checked this before coming out here, she was 12 years post-op and doing fine with it. There's a lateral view. I tried to fashion it so that it would sit on flush on the subtalar joint, just by decorticating the subtalar joint and then putting the stem in the calcaneus. This is a study that was done at University of Iowa by John Callahan and Charlie Salzman. 9-year follow-up, 7 to 16-year span. This was done on only the patients that were done before the joint was FDA approved. That was 94. From 84 to 94, there's a group they studied. By a single surgeon, they did an independent review without any participation on my behalf whatsoever. They did it then, and they're doing it right now, and I have some data on that as well. They did a clinical and radiographic review. Phase 1 phase 1 was the thinner tibial component of 22 ankles, and then 110 ankles from phase 2, where we augmented the back and so forth. I show this only to show where we put the distractor. We put the pin through the neck of the talus and through the calcaneus, and 2 pins through the proximal tibia. Indications, 2% were post-infectious, 23% rheumatoid, 29% primary, and then post-traumatic was 46%. There were, of the 126, there were 33 patients that were deceased. There were 93 patients living, and there were 15 ankles that either had to be revised or fused. And the 7 that were fused, I did 2 of those, both for infection. The other 5 probably may not have had to be fused. It was so frustrating. I would get a call from a physician or a patient and say they have to take my ankle out. And I would say, why? And they said, well, you said it's failed. And I said, well, how did it fail? Send me some x-rays. And well, the surgery's already scheduled the day after tomorrow. So by the time I got the x-rays, which was a non-union of the syndesmosis, some subsidence of the tibia, subsidence of the talus, both of which could be fixed, or all 3 could be fixed, the ankle was already taken out. So that was a frustrating part of the whole thing. But in any event, I did lose 1 ankle, used a thigh tourniquet on someone who'd had some atherosclerotic plaques in the femoral artery, and the patient lost his leg. They analyzed range of motion, progressive hindfoot DJD, syndesmosis fusion, and any large lucencies or actual lysis greater than 2 millimeters. They analyzed 77 of the 80 that were still living, 27 of 36 that were deceased, reviewing their x-rays, and then 13 of the 15 that were revised or removed. And 75% had some radiographic lucency, but that is not necessarily all bad. This is the zoning that they portrayed so that it could be categorized. And 37% of them had a lucency in zone 3, which is the keel, and 20% circumferential. That's something you really don't want to see, I guess, in any joint. Not all lucencies are problematic, particularly the ones that are lateral, or medial for that matter. Stress shielding plays a part here on the medial wall and the lateral wall. So I didn't pay any attention at all to the lucencies there. As far as the hindfoot arthritis, there was 19% progressive DJD, and 15%, that's the subtalar joint, and 15% in the talonavicular joint. And some of the literature will quote as high as 50% following an ankle fusion. The syndesmosis, 50% healed in the first 6 months. After 6 months, additional 41%, 9% went on to a non-union. But even with a non-union, the ankle usually did pretty well. You had to be very careful going in and trying to correct the non-union and then get the ankle infected. So I was very cautious about proceeding along that line of trying to make things better when they're working good. Range of motion averaged 18 degrees. No correlation with clinical scores. The results of the retained implants, 92% of the patients were satisfied, 94% advocated, 97% said they'd recommend it to a friend. So their review was positive. They still had some pain in the pain score. There was 2 pain and disability, like 3.36. The tibial component did quite well, as you can see, even out as far as 14 years. Once the tibial component stabilized, it didn't move. The talar side, those 1 or 2 that did start to subside, you can see every year subsided more and finally collapsed. But this is out of 12 or 14 years. Why did they, well, the revisions done or fused? A loosening migration, and I mentioned 2 component fractures, and 2 were fused. I fused those for infection, both in the same patient. Conclusions, less hindfoot DJD than with ankle fusion. Syndesmosis bony fusion impacts the radiographic and clinical outcome with the agility. You'd love to see a syndesmosis that's solid, and the clinical and revision rate is around 11%. This is another study that I just got the data last week. University of Iowa was doing a second independent study. Dr. Salzman, no, not John Callahan is doing this. Of course, there are not a lot of patients still living. There's 37 living patients. They contacted 32 of the 37. There were 4 they couldn't get a hold of. 14 of 37 have a minimum 20-year radiograph. 13 of 37 have had a revision or a secondary procedure. That may be a poly replacement, fusion, syndesmosis, what have you. 12 of 37 had no secondary procedures. This is going to be presented at the AOFS in March of 17. I show this slide, you get all done with a total ankle, and you're walking out of the operating room, you're so proud of yourself. You know, you did a great job. You get an x-ray and PAR, and guess what? Here's your tibial component sitting anterior. You think, what in the world happened? And here the x-ray gal came by, lifted the leg by the toes, and pulled the tibial component out of the slot. And this has happened. That's why I'm an expert at it. But in any event, you got to be ever mindful of all the problems that you can encounter. This, going into another subject, but this is one slide that if you remember nothing, just remember the post-op ulnar nerve palsy are the predisposing factors. Someday you may have to use that article. Our office was plagued with post-op ulnar nerve palsy problems, and we were threatened to be sued. The hospital was blaming us for leaning on the patient's elbow. They were blaming anesthesia for putting on tourniquets too tight, for flexing the elbows too much, for positioning the patient wrong. Everybody's blaming everybody. So we set up a prospective study and followed 6,538 patients through their general surgical experience in 1 year. We saw them, gave them a form preoperatively, postoperatively, and then followed them. There were 17 patients that developed it, and there was no patient that we had leaned on the elbow and all that type of thing. Matter of fact, 7 or 8 of them developed it in their upper arm on a pillow with it extended. So for the next 10 years, I spent, I was in and out of court, 7 jury trials, and we won all 7 trials. After the 7th one, the legal system in the United States, I think they decided they'd had enough. And to my knowledge, no money has changed hands on this particular complication since. But I studied the opposite elbow as well as the affected elbow and found that both of them were compromised. The day I left the university here, Dr. Clausen gave me this saying from Longfellow: "The heights of great men reached and kept were not attained by sudden flight, but they with our companions slept, toiled up in the night." In the end, thank you. questions.
Frank,
Good.
did you address obesity and the ankle?
What's the question?
Obesity
Obesity?
and the ankle. What are your indications as far as BMI and things?
Well, the question is, do you do a total ankle in someone that's obese? Well, I think that if they are a large bone person like a farmer, that's heavy, he's got good solid bone, and he's a compliant patient. That was studied back at DePuy, and as to what the joint would actually tolerate stress-wise. And there were actually no official restrictions coming out of the engineering department of DePuy. And of course, it's left up to the surgeon's discretion, which means that you can get as much trouble as you want to. And but we never really limited it, because a lot of obese people are not very active, and some of them simply couldn't walk. If you have a bad ankle, they said, I can't walk, I can't go to therapy, I can't do anything, I can't get out of a car, I can't take 10 steps. I mean, so I guess there may have been, I don't know, Greg or Dr. Sanjorgen, maybe Ted, did you ever restrict any of them because of weight?
We did
No,
a study in Toronto where I did my foot and ankle fellowship looking at obesity and patient-reported outcome scores as well as revision rates, and we had no difference between BMI over or under 35.
Okay. Any other question? Yes.
First, I just want to acknowledge for the younger people that if it weren't for you and Dr. Kopet, we probably wouldn't have ankle replacements to study.
Bruce, my hearing is atrocious. I
I
can't.
wanted to acknowledge for the younger people in the room the role you played in keeping this option open to patients, because if it weren't for you, the two of you and Dr. Buchel, we probably wouldn't be able to study the impact of arthroplasty. So thanks for putting in that 20 years of effort to make sure we had the option to treat our patients that way. Knowing what you do now, do you think there's a big role of torsion in the development of ankle arthritis, and do the ankle arthroplasty designs help us manage that?
That's the question is torsion a factor?
Yes.
Well, I think that if you look back at the earlier implants that were cemented in place, that was the problem with no torsion possible. They were a rigid implant, and they failed very quickly. Well, especially with the cementing techniques at the time, so it's not really comparing apples to apples. But I think there has to be some slop built into the joint, and in the agility, even the later versions of the agility still had slop built into it, particularly in plantar flexion. Once the ankle was in neutral or dorsiflexion, it still was not rigidly fixed in the sidewalls. It still had some medial lateral movement and some axial rotation, which is, in some minds, good and bad. In other words, when you make it actually rotate, then theoretically, you're making the poly incongruous. And even the newer implants are going to be facing that same problem with the stem on the dome of the talus. And the actual forces work on that, that's going to wear that slot out just as much as it wore out any sidewalls on the agility ankle. So I think, yes, I think torsion is something you have to configure when the joint is designed. Any other question? Yeah.
Great job. Great job.
Yeah.
Next is going to be Dr. Ho discussing P. acnes in the revision shoulder.
Thank you, Sean. Thank you, everybody. Thank you, Dr. Zura, Dr. Alavine, for sharing your experiences with us. Leave it to the University of Washington to keep me humble on the day of graduation by putting me in a room full of people and speak publicly. Remind me of my lifelong fear of doing so. Our project today was mentored by Dr. Mattson. It is called The Characteristics of Revision Shoulder Arthroplasty Patients Who Are Culture Positive for Propionibacterium. So another long title for the day. Propionibacterium are anaerobic gram-positive rods that are part of the normal body flora, typically thought to be a low virulence pathogen. In the context of shoulder arthroplasty, they are a diagnostic challenge. There have been multiple series of patients, both open and arthroscopic shoulder patients, who have had propionibacterium cultures, but have had relatively benign clinical presentation and also with relatively normal inflammatory markers with normal or near normal white cell count, CRP, and ESR. They're also a microbiologic challenge. They're somewhat fastidious, and they require an optimum of 13 days incubation for appropriate length cultures. Even so, Dr. Mattson's group has recently shown that 40% of shoulder arthroplasty patients that are revised only for pain and stiffness have positive cultures for propionibacterium. Given the low virulence and the high incidence of positive cultures in shoulders that are revised with relatively clinically benign presentations, the question is raised whether or not propionibacterium culture positivity is significant for their clinical course. And is the mechanism of failure different in failed shoulder arthroplasties that are culture positive than those that are culture negative for propionibacterium? So we completed a retrospective review of 190 revision shoulder arthroplasties. We looked at the preoperative clinical and radiographic findings in addition to intraoperative findings. We had an independent reviewer look at the radiographs and then a separate reviewer look at the clinical and intraoperative findings. We excluded all shoulders that had incomplete records, and we had 132 shoulders that met criteria, and subsequently we completed a univariate analysis. This is a summary of the results for clinical characteristics. Shoulders that were propionibacterium positive are more likely to be male, more likely to present later after the index arthroplasty procedure, and less likely to have diabetes, also less likely to have a failure from mechanical etiology such as a fall, instability, or rotator cuff failure of the shoulder. In regards to the intraoperative findings, significant findings, differences were found in the level or amount of glenoid changes such as glenoid erosions, osteolysis, or loosening. Also, there was a significant number of patients who had a humeral membrane, a membrane that was found between the endosteum and the component on the humeral side, a surgical cloudy fluid encountered on arthrotomy, as well as a significant number of patients who had polymicrobial cultures found during surgery. This is some of our radiographic findings. It really just kind of backs up the intraoperative findings, and that radiographic findings show there are significant glenoid changes as well. To summarize those findings, so again, propionib-positive cultures associated with male patients. They're likely to present later, on average 12 to 13 months further out from their index procedure than those that are propionibacterium negative. Less likely to have a mechanical etiology as a result of the resulting in failure of their arthroplasty. And the radiographic findings tend to match the intraoperative findings, particularly focusing on changes in the glenoid. And also, propionibacterium culture positivity is more likely to be associated with polymicrobial cultures. So we propose that the presence of propionibacterium causes a low-grade infection that leads to slow bone loss and delayed presentation. The limitations of our study, this is a retrospective review. There was somewhat inconsistent microbiologic handling in terms of the length of cultures, the number of cultures that were collected, and it's still difficult to ascertain what constitutes a true positive result. Our positive results range anywhere between 1 out of 8 samples with propionibacterium bacterium growing in broth only to multiple samples growing P. acnes with significant positivity. And that leads us to the future directions. I'd like to work on finding a way to improve the detection of propionibacterium bacterium, but also how to optimize our protocols and potentially finding a way to stratify our patients looking at the positivity of our cultures. In conclusion, propionibacterium bacterium is highly prevalent in field shoulder arthroplasties. The mechanism of failure is different, and to keep in mind infection, even for patients with rather benign clinical appearance. Thank you to Dr. Matson, Akash, one of my co-residents, and one of our medical students, Michael Chen. Any questions?
Good. So before you did the study, you had a strong sense probably that P. acnes were indolent infections that can present in mysterious ways or not at all.
Yeah.
Now that you've done this, what would you do or think differently as a shoulder surgeon?
So, interesting question in that when I started this project, I talked about it with a couple of my co-residents, and my thought was, you're culturing something for 3 weeks sometimes. It's being handled by how many people, and it's showing up in 1 sample out of 8. And so I was a little skeptical. But actually, talking to Dr. Matson and seeing what he's done, he has a protocol now for stratifying his patients. So he looks at if they're male, if they have glenoid erosions or osteolysis, if they delayed presentation. And because he does a single-stage revision, he doesn't want to wait to start postoperative appropriate antibiotics. So he has a protocol where he is able to start IV antibiotics and keep those running for folks that he thinks that are higher risk for having P. acnes grow. He has a yellow protocol and a red protocol for that. And actually, I think that's something that we need to look at and see how they do. So
It seems like the
TBD.
Yeah, sure. It seems like the glenoid erosions are a big finding of this study. So knowing that, how hard do you go looking for them? I think for this it was on plain X-ray if I remember right, but
Right.
now that you know that that's a place where you could go looking, is it worth CAT scans?
I think for the majority of our shoulder patients, it's apparent by radiographic analysis, and that CT scan might not be necessary. But this is in the context that total shoulder arthroplasties traditionally have been thought to have significant difficulty with the glenoid to begin with, and the whole rocking horse phenomenon. So you have to take it in the context of the whole patient.
So to reinforce the question, these are polymicrobial infections?
Not all of them. About 50% of the patients who had P. acnes grow were polymicrobial. So potentially there is some sort of synergistic effect or some sort of, it's a gateway microbe, that the virulence factors produced by P. acnes allow for other potentially low virulence bacteria to also take hold and develop a quorum.
And so the reason that I ask that is the P. acne a problem with just shoulders, or is this an upper extremity problem? As in, I have a loaded question,
Yeah.
infected total elbow.
I think there's literature for total elbows, although I think colic-negative staph is more common in total elbows. There's also some good data for spine surgery. Also, there's some data in the trauma literature as well, although I'm not as familiar with that.
Also hips.
Thank you.
Next, Dr. Mickelson will be talking about his crowdsource assessment technical skills related to performing knee arthroscopy.
Thanks, Sean. So I'm going to change gears a little bit and get into education and technology. Most of my
earlier residency research was doing a Dupuytren's manipulation study with Dr. Huang on, it was a randomized controlled trial, and I presented that enough times that I think everybody's heard it a few. So just to save everybody, I shifted gears. And given my computer engineering background, my interest in education, my future in sports, decided to go forward with this project with Dr. Green over the last year or so. So to start, we'll just touch on the project's concept and design. To give you a good background, we'll have to talk about our assessment tool called the Asset and what crowdsourced assessment of technical skills is. It's a pretty new, novel way of assessing surgeons and trainees. And then we'll touch on our study design, the data and findings, and some conclusions and future projects. So the educational landscape, as you know, is shifting. It's shifting towards a competency-based training, and it requires good objective evaluations of resident competency. For sports, the cornerstone is arthroscopy, and we do this in their operating room, simulation, dry skills lab, and being able to assess them has its challenges. It's both time-consuming, it has risks of bias, and it's costly, especially for using attending physicians whose time is very costly. And so in an ideal assessment tool, it's simple, it's comprehensive, it's unbiased, it's fast and reproducible. And using technology, sometimes we can have these best of both worlds. So using CSATs, which is short for crowdsourced assessment of technical skills, and an arthroscopic general assessment tool called the Asset, our study looked to see if we could have the crowd, which are lay people that aren't specialized in surgery, a large group of them using the CSATs tool to evaluate arthroscopic skills using the Asset score. And our hypothesis was that they would be able to assess residents and their skills equally to or close to that of expert surgeons assessing the residents on videos. So to start, the Asset score stands for the Arthroscopic Skills Surgery Skills Evaluation Tool. It was actually developed by a graduate of here, Dr. McAndrew. Dr. Warren from here is also involved. And it assessed global arthroscopic technical skills. It's generalizable. It's not per a specific procedure. It can be used in shoulder scopes, in knee scopes, and it's both for live and simulated environments. It has 8 domains that are evaluated, and each is on a 5-point Likert scale using a Dreyfus model where you progress from a novice through competency to satisfactory or then to expert as well. This is it. It's pretty busy, but just to zoom in, there's 8 different domains. It goes from safety to field of view to your dexterity. It also looks at your safety. And just to look at a few of them, field of view, if you're a novice, it's a narrow field of view, inadequate arthroscopic or light source positioning. And if you're an expert, it expands you kind of pulled back, optimal view with good lighting. For instrument dexterity, if you're a novice, they grade you as an overly tentative and awkward with your instruments. And if you're an expert, you have confident, very accurate use of your instruments. So this has been published on research in a number of studies. This one's from 2015. The Asset was first developed in 2013. And here they recorded diagnostic arthroscopy of shoulder and knee procedures by residents, fellows, and faculty. They had 2 blinded raters that assessed these videos using the Asset score. There was a total of 70 videos, split pretty equally between shoulders and knees, that evaluated their Asset scores. They showed that the attending and fellows had higher Asset scores than the residents, and there was a fairly good rater concurrence of 88% on pass-fail. It had construct validity, and it also had good, fairly good rater reliability. Their Asset score interclass correlation coefficient was around 0.8 to 0.9, which is in line with the OSATs or GOLD, which they use in laparoscopic surgery. Shift gears. We'll touch about what crowdsourced assessment technical skills is. A novel way of assessing people. It actually came out of the University of Washington, Dr. Lenve, in urology, mostly for robotic surgery, where they record it and assess it through the crowd. This has been used in a number of surgeries now with urology, ENT, laparoscopic surgery skills. And what is crowdsourcing? For those that don't understand, it's basically leveraging the power of the internet and the wide public using the internet to do this. They do it in a number of ways. There's crowdfunding, where you might have something like Kickstarter, where people ask for some money to support a cause, and small little transactions from a number of people, thousands of them, raise funds for that project. There's also crowd voting, basically surveys to a large population to get their perspective on a topic. Crowd contests, where say a company wants to create a logo, doesn't want to pay a firm, so they have a crowdsourced, basically a contest, and whoever wins that, they get to look at hundreds of logos, and then they get to pay the one that they want. And then microtasks, which is where this falls in. It's basically dividing a large project into small tasks, putting it up on the internet, letting the crowd do those tasks, and then have it come together as a completion of a larger job. So this is just a little illustration. You basically have your project here, and you break it into tasks, you put it in the cloud, which are called human intelligent tasks. Workers are then assigned to these tasks and submit their projects. They basically paid cents to dollars for their time. These are all collected and then given back to the person that wants the project completed. And a common way of using these Turks, which is the name that Amazon gives to these crowd workers, is called Amazon Mechanical Turk. And who are these Turks? They are located a lot in India and the United States. Just over half are female. They mostly fall in our age range for residents, and most of them have a bachelor or graduate degree. They're doing this on the side, it seems. CSATS itself is a platform that basically leverages the Amazon Turks. They have video from any type of skill set, either from laparoscopic or robotic surgery, in our case arthroscopic surgery. That's uploaded to the platform where the Turks then evaluate these videos, give their assessments, and then these are provided back through the final assessment tool for continuous improvement or for evaluation of trainees. So for our study, we actually used the videos, thanks to Dr. Nicandri, of his asset validity test for arthroscopic assessment in both his shoulder and knees. So he had 70 videos, and these were already scored from that study by two blinded experts. We excluded the autonomy domain. That was actually assessed based on how autonomous the resident or trainee was when they did it by somebody that was standing there. So that was not able to be assessed by the crowd that was just looking at the video. Given a power analysis of 0.8, we found that we needed about 12 videos to start of the knees and the shoulders. So 24 were selected randomly, 12 from each per quartile, 3 per quartile. And these were uploaded to the cloud. These Turks basically viewed a training video to kind of get them to understand what an arthroscopic diagnostic arthroscopy of the knee and the shoulder are. They also were given a little background on what the asset score is and what that is. They did a side-by-side discrimination video for the platform to ask them to make sure that they were able to identify who was more experienced or not. These results are summatively used to curate this pool of evaluators in the crowd. And then they're given any number of videos that we've just selected and uploaded of our 24 to evaluate, basically going through and giving them their asset score as they proceed through, and they can do any number of these. So as far as our results, we used the two blinded expert surgeons scores that were previously used in Dr. Nicandri's study, and then our crowd assessed the 12 shoulder and knee videos. They were assessed around 50, by an average of 50 different people. In the crowd, there was about 266 unique Turks that actually evaluated these videos. They did about 1,300 assessments, over 600 of both, and this took them about 4 hours once it was all uploaded and introduced into the system, which came out to be a domain assessment around every 10 seconds or so. So these are the results for our shoulder. The correlation for what Pearson's correlation coefficient was basically 0.6. We see here that the crowd assessed people for the shoulder, giving them slightly higher scores than those of the expert scores. But they still were able to get a correlation of about 0.6. When we broke it down into the actual quartiles, the actual middle two quartiles did not line up. That was actually primarily from the safety domain when we looked at the data further, which we still are. But when those removed, the quartiles lined up better. And then this is for the knee. The knee correlated better. It was a 0.74. The experts on this side actually evaluated the trainees with a higher score than the crowd, who was a little tougher on them. And these quartiles lined up similarly compared to the experts and non-experts. So in conclusion, for this basic kind of validation and study is that we think that arthroscopic knee and shoulder evaluations using the assets tool by these non-experts in the crowd do demonstrate an adequate correlation with our already expert graders. The knee evaluations by the CSATS platform had a better correlation than that of the shoulder. Crowdsourced assessment technical skills appears is a valid tool that can quickly evaluate arthroscopic skills of trainee, though it doesn't support high-stakes pass-fail determinations. This would be more, at least initially, for overall evaluation of their skills and trends. The platform is shown in studies in urology and laparoscopy is that as further studies are done and these crowds are trained, especially specific Turks that assess these on a more regular basis and are given feedback from the platform and how they're doing, that they can get these correlations much higher into the 0.8, 0.9 range. So we have future projects are interested in leveraging this platform both for looking at other assessment tools beyond the asset and then for actually using it for evaluating pre-post of residents on clinical rotations, on a week-long arthroscopy intense course that we actually have here at the University of Washington, and then also on surgical simulators. I'd like to thank Dr. Green and Dr. Nicandri, Lauren, who's one of the third years here, almost fourth year. Any questions?
Yeah, I have a question. Looking at this, Dean, how do we know that these people are going to say the same thing, the same group, 6 weeks from now? As in, you have a correlation value, 0.7. But is that going to hold up next time you do this? Do you have a kappa value on any of this stuff?
Not that I'm aware of. It's hard. We just ran this one time, but as far as continually, the platform, I guess, collects all this data and is able to evaluate over time how the Turks evaluate and what the consistency is. They've actually are able to select people that are not consistent with their evaluations, and they actually have put back in old videos into the system to see if they're evaluated similarly, to make sure that those people, outliers, are excluded, or to identify these evaluators in the crowd that are consistent and good. And then they actually get, from what I hear, early access to these videos to be able to, or get paid more to be able to evaluate these videos. So they try to select out the evaluators that are consistent, so it's reproducible.
And then, do we have a minimum number that makes it valid?
Minimum number of evaluations or videos that need to be?
Of evaluators.
They said it's about, they said around 50 is what they said is what they want. 30 actually, between 30 and 50. They said it depends on how complex the assessment tool is.
Okay. And where did that number come from?
That came from them, from the urology literature, from what they've been able to demonstrate.
Because, as it was pointed out to me, if we look at crowdsourced knowledge, the economists really got it wrong yesterday when it came to Britain and their exit from the EU. So
this is mostly United States and Indian people, so that's good.
Dane, what's the cost, or what would be the projected cost to a program to use crowdfunding?
It's so it's early. This study took about a couple grand to set up. It's mostly setup fees for them to upload the system and get it in the platform, and then they actually have now just spun this out of the University of Washington as a company. And from what I understand, they want to. It's it'd be $100 a year for a resident to be evaluated through this platform in any number of ways. I think depending on how robustly you use it, it would depend. But it's mostly setup fees, which is a few $1,000s. Once the asset score is in the system and once the crowd has basically been set up, you just basically upload videos, and then they just continually do it. And the cost to the crowd or to the platform isn't that much because Turks get paid cents, if $1, for multiple assessments. So it's not that expensive. These people don't make a living off this. It's kind of a fun side job. Alex?
So if this is going to be used kind of in a residency type model, how do you improve off of it? Do they evaluate you on safety, on different skills, or are you going to have to sit down with an expert who is going to look over this again and say these are the areas that you need to improve?
Yeah, I mean, it's not a standalone model. There's actually a whole dashboard. The future is to have a dashboard for a resident performance that you can go back and review your evaluations, your videos, look at ones that have been rated well beyond what you've done. So that would be the way to be able to do it. And then obviously, ideally, it'd be independent where you could do a scope on a cadaver or on a simulator and then upload it into the system and have it evaluated very quickly by the crowd and then be able to see how you're doing compared to your peers. As far as it being self-sufficient, I think it has to be followed by attendings. I mean, it would have to be monitored by faculty. It can't just be you and a computer. So I think that's the vision that they've had for this, at least in the robotic surgery. They're also using it apparently for kind of licensing and getting your privileges, and also doing it like if you can gown and glove, and if you can do small procedures, nursing procedures, or things like that to get certified, I guess.
I think it's really exciting. I think it has a lot of implications potentially outside of education as well. And I'll get to that, but I have some concerns when you're basically doing a gold standard study. And your gold standard was just 2 expert surgeons reviewing these. Do you have any plans on redoing that with a lot more people on the expert side reviewing these surgeries and these videos before we see if the crowd can figure out if there's concurrence or not?
Absolutely, yeah. 2 experts, even though in the Kandri paper it was what was used to kind of show their initial study, we needed to be much more robust. So this kind of all fell into place great because they had the videos, they'd already been assessed. We were able to plug them into the system and get a pretty quick study done. But our plan is to have these videos, there's a few other batches of videos, and then do a prospective evaluation of them and have it assessed by a number of attendings and faculty in sports, and then also by the system to be able to actually get it. And the hope is that as this crowd becomes more mature evaluating arthroscopic videos, which is the first time that it's been used for, that they'll be able to get better, but we will be able to.
And then am I wrong in just kind of making the assumption that the crowd is just the population?
Yeah, it's just.
That is wrong, or that's okay?
That is, it's the mass of, it's
just the masses.
Some of it's self-selecting of people that want to do this, but none of them are specialty trained or.
But it's really an interesting thing. It's basically, people, the great ones make it look easy, or if you're looking at pornography, that's the definition. You know what it is when you see it. But the masses can figure out what's good. And you could potentially see marketing or advertising opportunities in this. If you're slick, you put your best video on your webpage, and an untrained person will recognize your quality. And there's a lot of ways to use this other than just education.
Yeah,
it's really exciting.
Average of the masses are actually pretty smart, potentially. Dr. Kennedy?
Dana, in your example, you used these Turks, but another option is looking at crowds. If you look at like Google, they knew that there's all these people who are, there's always want to make sure that you're not a robot when you're logging into something, so they have those little letters that you choose out. Well, Google said, well, we have this huge crowd of people that are doing that for free. I wonder if we could use that. And so, they have this problem that they're digitizing all of these books. And so, the computer can figure out a lot of the optical character recognition, but there's a few that are kind of hard to read. So they use the human beings that are already filling out these things for CAPTCHA, and then use that. And so you're actually, oftentimes when you're doing that, without realizing you're working for Google or things like that. And so it might be interesting in future if you're looking for a crowd. Our patients are really interested in seeing some of their own procedures being done on a video while they're sitting in a waiting room. And so you may be actually get them to review our residents anonymously without even realizing it for free. So that might be, they would get out of it. They're waiting anyway, and they're kind of interested. Oh, cool, surgery. And then you ask them at the end, hey, which person did you think was better, more adept at, getting their arthroscope around the knee? And then that feedback could be used for our residents.
That's a really good idea.
It's really interesting. I've worked near Dr. Lindsay for a couple of years now in Bellevue. He's expressed his enthusiasm about this and has been tweaking me to get you all to look at your arthroscopy work more critically by asking me, do you give the resident the DVD to look at it afterwards to see how they did? And so I'm really interested in continuing this as an evaluative tool. And even the little bit you mentioned about review of nursing, a simple procedure like having a video in a room and seeing if a resident can set up the arthroscopy and what kind of hand maneuvers they go through, not just the images they generate on the screen, but what they're doing in the room, I think could be really instructive. So thank you.
Yeah.
Our last resident presentation will be by Dr. Teleria discussing coronal plane fractures of the distal femur. Well, good morning. My name's Jess Teleria. I'm one of the graduating chief residents, and it's my pleasure today to talk to you about my work looking at coronal plane fractures associated with supracondylar, intercondylar distal femur fractures. And I'd like to thank, again, Drs. Zura and Alvine for being here with us today, and also to acknowledge my co-authors, Drs. Beret and Drs. Nork, who ironically are in the middle of fixing a distal femur right now. I have nothing to disclose. So distal femur fractures, when they occur in isolation, are known as Hoffa fractures, as they were originally termed in the early 1900s. But thanks to some prior work already completed by Dr. Nork, we know that coronal plane fractures are present in nearly 40% of these higher injury supracondylar, intercondylar distal femur fractures. Operative reduction and stabilization of this coronal plane fragment is mandatory to help prevent displacement and mitigate development of post-traumatic arthritis and to optimize patient function. The optimal construct for the coronal plane fracture would maintain the reduction reliably, allow for early range of motion to prevent knee stiffness. It would avoid interference with the lateral locking plates that are typically used to fix the supracondylar component of the fracture, and they would be cartilage friendly. There are many options that have been used and reported in the literature, but however, there's no consensus on what is the best form. Typically, either large fragment or small fragment screws are used, or sometimes supplemental plates like a rim plate. Hoffa fractures, or also known as coronal plane fractures, in isolation have been successfully managed with small fragment constructs, including 2.4 to 3.5 millimeter screws. This has been reported in the literature already. However, no one has reported outcomes of these fracture fragments radiographically when associated with the supracondylar, intercondylar distal femur fracture. Therefore, the purpose of this study was to report the radiographic outcomes of fixation of the coronal fragment when associated with these injuries. And it was our hypothesis that the small fragment screws would be sufficient to maintain reduction. This was a retrospective chart review from a single orthopedic institution over a 12-year period of time. Our exclusion criteria included skeletally immature patients and those that were lost to follow-up prior to 6 months, and that included patients that were deceased or those that were unable to return due to geographic reasons. And then we also excluded patients who had the coronal plane fragment treated with anything other than a small fragment screw. So the surgical management of these injuries were typically a direct lateral or lateral parapatellar approach. If there was a medial-sided component, a supplemental medial subvastus was also performed. Typically, the articular block was reduced and the coronal plane fragment was definitively fixed. We used small fragment countersunk screws that were placed in the lag technique in the sagittal plane. And thereafter, the articular block was then reduced to the metadiaphyseal segment using a lateral locking plate. Segmental defects, which were unfortunately quite common, were treated with antibiotic beads or a cement patty with planned staged bone grafting via the Masquelet technique. So you can see here an example of fixation construct for the coronal plane component. We have the provisional reduction here being held with K-wires, and then 2 small fragment screws placed in the sagittal plane, ideally perpendicular to the fracture fragment. And then a lateral locking plate was then used to reduce the articular block to the metadiaphyseal segment. And what's good to note here with the red arrows, as you can see, the small fragment screw is able to traverse the screw corridors through the lateral fixed angle implant. And for anyone who has been involved with one of these fractures, you know that the real estate there is used up quite quickly. Our postoperative protocol involved 48 hours of soft tissue rest, then followed by range of motion as tolerated to the knee. The patients were maintained non-weight bearing for 3 months. And at that point, if the radiographs were reassuring, they were allowed to begin a progressive weight-bearing program, which lasted approximately 4 weeks. Radiographs were obtained at the 6-week, 3-month, 6-month, and 1-year follow-up appointments, and thereafter annually. And then statistical analysis was performed. So looking at our results, this large diagram on the right-hand side here demonstrates our enrollment. So we began with 127 knees, excluded all the patients that did not have a coronal plane component, then excluded patients that did not have fixation of the coronal plane fragment, typically no fixation of the injury at all. These are patients that either died in the immediate post-injury period, underwent an amputation due to usually a severe blast or crush injury. A few patients required an oncologic total knee, and then one patient received a fusion. That left us with 62 knees, and then we then excluded any patient that did not get a small fragment screw as the form of fixation for their coronal plane fragment. In all, we ended up with 56 coronal plane fractures and 44 knees. Both condyles were involved in approximately 27%. 27% also only had a medial injury, and then almost half of our population had a lateral-sided coronal plane fracture. The age distribution is listed. It was approximately 61% male with an average age of 43 years. And if it wasn't already obvious, these are quite severe injuries, and 75% of them were open, predominantly a Gustilo-Anderson type 3 injury. The average injury severity score was 21, again highlighting the polytrauma nature of these injuries. The majority got a provisional X-fix, and definitive fixation was performed on average 6.5 days later. Our typical construct, most commonly used, was two 3.5 millimeter cortical screws, which was approximately 40% of our population. These again were placed in lag technique and countersunk below the articular surface. All of these coronal plane fragments were fixed with either 1 to 3 small fragment screws ranging from 2.4 to 3.5 millimeters in diameter. Our average follow-up was just about 2 years. It's important to note that 34% of our patients underwent a secondary surgery. These were predominantly unrelated to the coronal plane fracture itself, and most commonly repair of a supracondylar non-union, which occurred in 20% of this population, or for planned bone grafting that was planned at the time of the index surgery. When looking at these injuries radiographically, 98.2%, so all but one knee, the coronal plane fracture healed uneventfully with no evidence of displacement, which we defined as 2 millimeters of gapping or step-off. One knee underwent a supracondylar non-union, which did involve the coronal plane fragment itself, developed avascular necrosis, and ultimately underwent an arthrodesis 1.5 years later. This particular injury represents the only failure of the coronal plane fragment, if you could attribute it to that in the study population. So there are a lot of advantages to small fragment screws. As I already indicated, they're able to weave through the fixed angle implants used to reconstruct the metadiaphyseal segment. This is much more difficult to do with a large fragment screw. These smaller screws are able to target smaller fragments, and similarly, you are more likely to be able to put multiple screws into a single fragment. They have relatively minimal cartilage loss when compared to larger screws, as less countersinking needs to be performed through the articular surface. And you are able to place them in the sagittal plane, perpendicular to the fracture line, and achieve as much compression as possible. So that's not unique to a small fragment screw. You can do that with a large fragment screw, but that is more difficult if you're using a supplemental plate. And then there's less soft tissue irritation, especially when compared to a supplemental plate. Results of isolated Hoffa fractures have been reported previously, as I mentioned, and successfully addressed with these small fragment screws. Our study would agree with what's previously been reported, and indicates also that in a more complex severe injury, such as these supracondylar intercondylar fractures, that small fragment screws are also sufficient to maintain the reduction. Biomechanically, 3.5 millimeter screws are sufficient as well. 2 screws are known to have approximately the same stiffness of a single 6.5 millimeter screw. And while many of the people in the audience may be thinking this is obvious, that you would put a small fragment screw in the sagittal plane, as we train here, this is not ubiquitously performed in all centers throughout the United States, and especially internationally. And when drafting this manuscript, that was our target audience to try and disperse this information. There are a number of limitations to the study. Most importantly, functional outcomes were not reported. And this truly, at the end of the day, is what matters to patients and hopefully matters to surgeons. But that was not an objective of this study. It's also, given the high energy, polytrauma nature of these injuries, it's hard to determine exactly what proportion of the morbidity is contributed just to the coronal plane fragment itself compared to the remainder of the articular damage and metadiaphyseal comminution. Initially, early on in the study, CT was not routinely obtained prior to fixation. That quickly changed, but it is possible that we missed some coronal plane fractures early during the collection period. We had a fairly high attrition in this study, which is unfortunately a rampant problem in this institution, as we're a tertiary referral center and many of our patients come from hundreds of miles away. And once their immediate postoperative care is completed, a lot of the remaining care is delegated to the provider in that patient's local area. And we sometimes, frequently, never see them again. So in conclusion, coronal plane fractures, when associated with these supracondylar intercondylar fractures, can be reliably maintained with small fragment screws when they're oriented in the sagittal plane. And larger screws and implants, which may make fixation of the remainder of the injury more difficult, may not be necessary. So thank you for your attention. I'd be happy to answer any questions.
Jessica, in these were all shearing, or appeared to be all shearing fractures. Was there, were there any that in the femoral, the larger fragment, there was a compression component that needed to be addressed?
In the coronal plane fragment specifically?
Not in the free fragment, so the posterior fragment. In the major fragment, you know, in shearing fractures around the elbow, for instance, the capitellum would be the equivalent of that. There's frequently a compression component that you have to address in the remainder of the capitellum, the part that's attached to the humerus. Was that true in these, or are these just pure shearing injuries?
So we did not specifically look for compression of the articular surface, so I can't provide those numbers. Having been involved with these surgeries, I know that that does happen, and it sometimes is necessary to elevate the articular surface. With respect to the coronal plane fragment itself, if that was necessary, those fractures were typically elevated and required some other form of fixation, such as a rim plate to buttress bone grafting and whatnot underneath that. The reduction of the coronal plane fragment in this study was typically performed indirectly with a radiographic reduction because the exposure required to get posteriorly enough to see that fracture fragment in most cases was felt to be excessively morbid. And so typically a percutaneous puncture wound was made and a clamp was placed. So I would say that with the depression, those patients were excluded from this study.
Okay, good, thank you.
I think this is, the great thing about this study is the simplicity of it, in the sense that you've gotten data now to what a lot of us do commonly. You know, and I appreciate your comment that the rest of the world may not. But I do think that we're moving more and more to fragment-specific fixation. We're moving to smaller screws. And there's some real biomechanic advantages. You get more threads in there, you know, per turn, and better pull out in some of those small fragment threads. So I think it's just, it gives data to what we do, and it sort of justifies what a lot of us do, and hopefully it will teach others. So congratulations on a great study.
Thank you. So that concludes our resident portion of today's talks. Next, I would like to welcome back Dr. Zura to speak about his experiences with the OTA.
Thanks for your indulgence in having me up here again. And I wanted to do a very different sort of style talk than earlier. I want to talk about the opportunity I had through the OTA to work twice, 2 tours, if you will, as a distinguished visiting scholar in Landstuhl, Germany. The reason why this sort of is something I've talked about some is, one, these conflicts are ongoing, though maybe not to the same level. 2, I'm not military. I'm not pretending to be military, and any of you are, thank you, and you're a hero. I'm not. I had the opportunity to be an interloper and kind of see how the system works and want to share that with you. 3, I was really misguided that we were in a skirmish, that we had, some guys over there having some stuff going on, but to kind of see the other side of it kind of gave me a sense of the magnitude of what was going on, and I try to convey that to you. And then finally, there was a Gallup poll taken of, as we become old farts, of the young generation, and it's, that 18 to 24 generation. What do people our age think about them? And it's sort of a recurrent theme, but it's, we talk about millennials, they're aimless or they're shiftless and they'll never amount to anything and they'll be no good. But those sort of studies come from the original Gallup poll in 1939. The exact same thing was said about the kids who went on to become the greatest generation. So this is just the cycle of life, that we think people who are 18 are no good, and it goes on and on again. So they were wrong in World War II, and we're wrong now. I can tell you, having met these kids, we're fine. We've got great young people defending us, great young people taking care of us, and it makes you really proud. I had kids with one remaining arm saluting me as they're rolling into the operating room and thanking you. So it's really an impressive group of people. So you can sleep a little bit better at night. So what this program is the OTA set this up as a Red Cross volunteer. So non-military people could go to Landstuhl and participate with the surgeons. And a lot of those surgeons are young, inexperienced surgeons taking care of volumes of patients. In fact, one of the people that was there when I went the first time wasn't even trauma trained, and he was taking care of all of the people out of Iraq and Afghanistan that came through. So it was a chance for senior surgeons, experienced surgeons, to go help some of our young Army surgeons. Started in 2007, there's been 50 OTA surgeons who have participated in these 2-week trips. We learn different things from every conflict, and again, those of you who have been in war know this. Perhaps in the Civil War, we learned about doing amputations quickly. In Vietnam, we learned a little bit about triage. What we've learned from this war is a couple things. One, the defining injury of this conflict probably is traumatic brain injury and PTSD. Over 100,000 traumatic brain injuries. But keeping the patient moving is what we've really learned, the ability that we really can get these patients moving quickly, and that's what I want to focus on. So this is an article from the Washington Post and a picture from the Washington Post, but they were talking about this private Solizano and how sick he was. But what they're going to do is, he was too sick in many of our hospitals. Even, they'll say, like the guy presented at Rounds this morning, too sick for you to examine. This patient may be too sick to get a CT in our hospital, but they're going to fly him out of Afghanistan into Germany. And that's their goal, just keep the patient moving. And again, it's just they're not only their willingness to do this, but their willingness to push the limits and get them out of the conflict. I love this line from Colonel Benjamin, where he says, continuity of care is not interrupted by a pesky little thing like moving the patient 10,000 miles to continue their care. So the most recent data I have, since I'm not on the inside, is from 2013. OIF, Operation Iraqi Freedom, and then the Operation Enduring Freedom was Afghanistan. This is all within the global war on terror. 52,000 kids were flown out of Iraq, and 23,000 kids were flown out of Afghanistan, just to give you a sense of the magnitude of what's going on here. Sorry, I read that. I saw the wrong side here. But up here, so 6,000 deaths. Again, you see the casualties. You see PTSD numbers are 125,000, over 250,000 traumatic brain injuries, 1,700 amputations, sorry. And then again, the volume of evacuations, 50,000 out of Iraq and 23,000 out of Afghanistan. That's 3-year-old data. Of the 19,500 Americans injured in Afghanistan, because it's not just Americans we're taking care of here, 6,500 have been treated in Landstuhl, Germany, and then most of them move home, trying to get them to their home base, but they either usually go through Walter Reed Brooke Army Hospital in San Antonio or San Diego. So these are sort of the levels of care that the patients receive. And level 1 is that buddy care. We'll go through this a little bit more in depth. You know, this is just the medics, and without it to a man, you hear about the Navy medics for some reason. They're really supposed to be a special group. But these are people who are carrying a machine gun and caring for people as well. I have had a patient at Duke who won 2 Silver Stars for taking care of people while he was returning and taking machine gun fire. So these guys are in combat as well as caring for the patients. Get the forward surgical team who'll stop the bleeding, debride wounds, and do dressings. That's in the first 24 hours. Then they get them to Bagram or a field hospital where they'll re-debride wounds, definitive care for the locals, maybe do an X-fix. And this may take as long as 48 to 72 hours. I was seeing kids in Landstuhl within 24 hours of injury in theater. Then they get on to Landstuhl, which is a full-service hospital, debride, close some wounds possibly, but not necessarily all of them. Some of the reasons for that is the Acinetobacter out of the desert. If some of these things were closed or fixed early, by the time they get back to the States, we would get feedback that they were pussed out again or infected again. And some of the infections are more severe than you think. If you ever have any question who the good guys and the bad guys are, you know, the insurgents tend to defecate on the IEDs as well to try to cause infection in our soldiers. So you're seeing different types of infections than you may expect just from a blast injury. And then they get home to Brooke Army or to Walter Reed or San Diego for their definitive care. So again, just sort of a picture show to walk you through. But again, the wounded warrior gets treated by the medics early on. Again, this is tourniquets and pain medicines, and this is that first hour. They travel by Black Hawk, not by the Chinook, because, as you know, we've filled the country with rocket-propelled grenades, so you need a fast-moving helicopter to get them out because they're being shot at as they're moving the soldier out. If you bring in the Chinook, which is too slow, though bigger, they're going to get shot down. Get to a forward operating base, and typically there you have an orthopedic surgeon and a general surgeon. You'll do I&Ds, amps, and X-fix. They do no other surgeries there. Orthopedically, no fixation will happen at this level. Then again, by a fast-moving helicopter, they'll go into Bagram in the northeast or to Kandahar. Those are the two cash hospitals. And again, there they'll stabilize, do repeat I&Ds, amputations, X-fix, revisit abdominal wounds, definitive care for the locals, and then move the rest of them on. And they get on these giant planes in Bagram or Kandahar, the C-17s, and they fly them up to Landstuhl. And here's just a picture of those planes. You can get a sense here. They're just lined up on the runway just to get a sense of the volume of injury coming in. And they take them to Landstuhl, Ramstein. It's Ramstein Air Base is immediately adjacent to Landstuhl Army Base, which is the hospital. It's actually the site of an old Hitler youth school. It's now an Army base. Little different hospital than you guys have here, maybe what you need in New Orleans with our crime rate. But you're inside of a perimeter gate that's armed with guards at this point. You have to, for me, I had to get in with my passport, and you can see that there's bomb barriers and a little different setup than you may be used to. You can see there, that's the only 3-story building on the complex. Now again, when you're in Germany and you're safe, but this is the layout. You know, past building 1 is where we stay, and then a trailer past 14 is where the orthopedic clinic was, so it's an incredibly long walk. It's 3.5 miles of hallways, and this is all about 1 story tall. And the reason for that is it's designed to sustain a bomb blast, that if they get bombed with just 1 corner, rather than being a vertical structure, it just takes out a corner of it, and you can continue to work in the rest of the hospital. So you kind of get a sense on how these people are thinking and working when you're there. At Landstuhl, the survival rate is 99.5%. Maybe the healthier ones make it out, make that 10-hour trip. The average length of stay is only 3 days, and then they move on. My 2 experiences there, I went in 2010. I spent Thanksgiving with the troops, which was special, and I did 55 cases in those 2 weeks, which was included a Thanksgiving Day. And then in 2013, I went back in mid-November as well and only did 15 cases. So the volume has decreased as the conflict has waned. Similar severity in those sort of patients, so maybe there's less volume, but we're seeing the special forces guys. I don't know why they think they're hidden. It's just that they have a beard and they tell you they're special forces. I go, I know you have a beard. You can figure it out. But a lot more beards on the second trip, but the same sort of injuries. So the way I wanted to kind of just convey to you the magnitude of what's happening is my first trip there, I didn't take pictures the first week because I just sort of feeling myself, I didn't want to be that guy in the operating room. So the first Monday that I took pictures in the second week, the week of Thanksgiving, I just am going to walk you through the cases from one single day on Monday, November 22nd in 2010, just so you can get a sense of what's coming through. And we ended up doing, I think, 8 cases that day. I just wanted you to see them and kind of see what we're dealing with there. The first case is a 20-year-old who was wrestling with his buddies. Again, since all they do down in Bagram and Kandahar is X-fix stuff, they X-fixed a closed tibia in a 20-year-old and then flew him up to Lonsdale. But if you think about it, you got 200,000 18 to 24-year-old guys living in theater. You have just sort of regular run-of-the-mill injuries. So we actually fixed him because he was closed, he didn't have any bomb blast injury, took his X-fix off, and it didn't nailed him. I think it was one of the few fixations I did in 4 weeks there. Second case is this gentleman who was he was a gunner. He was in a rollover motor vehicle sort of accident. He had right upper extremity wounds, fasciotomies, been debrided and vac in Afghanistan. He was injured on either November 14th or 15th, and he's in Lonsdale by the 16th. He'd been washed out on the 17th, washed out on the 19th. Again, as soon as they touch that desert sand, you just keep washing him out. So here he is on November 22nd. He had a repeat IND. He had wound vacs, closed reduction percutaneous pinnings of his 5th metacarpal fracture. You see his fasciotomy there. Third case, this is a Georgian soldier of Georgia, the country, not the state. He had been injured by a rocket-propelled grenade. So he had multiple right upper extremity sort of fragmentary wounds. He had hand fractures that had been pinned, and he had some bone loss. He'd also had a knee traumatic arthrotomy that had been IND'd and closed by this point. Again, he was injured on the 17th of November. He was in the Lonsdale OR on the 18th. So within 24 hours, he was in Germany being operated on. And this is, a NATO coalition soldier. This isn't even a U.S. soldier, and this is all U.S. care for this person. Operated on the 18th, the 20th, and the 22nd. And again, since he's NATO coalition, he gets his definitive treatment in Lonsdale. And then once he's healthy, he can go back to his country or go back to theater. So we are providing care for those other countries as well. So again, here he is on this day. We washed out his wounds, did a ray resection, a lot of Integra, put some Integra on there, and he had wound vacs. And that's his hand, but you can get a sense here, the rocket-propelled grenades are designed to fragment, so a lot of these people will have these just multiple wounds going up their body. You can see the wounds from each of those different grenade fragments there. And that's where we ended up with his hand. Fourth case was a 24-year-old Marine, dismounted IED. Dismounted IED means that he was walking. So he was walking when the IED went off. A lot of times, you may know this as well, a lot of times the caregivers are injured as well because there's often a second IED placed by the first. So they blow up the first person, then when care comes, they blow up the second one, trying to get the caregivers. This 24-year-old kid had a left upper extremity amputation through his elbow, right lower extremity amputation through his knee, left lower extremity amputation through his knee, right upper extremity wound. So it was a 4 extremity injuries, but a 3 extremity amputation. He'd been X-lapsed. He's one of the few people who'd had a belly injury, but he had been X-lapsed with a diverting colostomy for rectal hematoma. He had bilateral orchiectomies. He had been repair of his penile deglovering. He had repeat explorations of his abdomen, and he had a massive transfusion. So there's a number of things to sort of talk about there. One, abdominal injury. The armor that they wear, it's a balance between weight and mobility and protection, and a lot of these guys will choose to pick some armor or not. Very few chest and belly injuries. Most of the general surgeons in Lonsdale, while I was there, would just assist on the extremities with us because there weren't a lot of belly and head injuries that were operative at that point. Most all of the Marines will tell you that they'll take off their groin protection because it just doesn't work, and it gets in the way and it keeps them from being mobile. So you see a lot of actually penile and scrotal injuries as well. There's actually a program set up for our soldiers to donate their sperm before they go because this sort of injury is so prevalent. Massive transfusion protocol, they really just talk about these walking blood banks, and a number of the kids we took care of were benefactors of that. So you'll be at your forward operating base, one of these kids will come in, and they'll just call out over the loudspeaker that we need, B positive blood, and people with B positive blood just line up, and so the other soldiers on base just start giving their blood, and they'll transfuse whole blood. And that's how they have the blood bank. It's just a walking blood bank that you give to your buddies when they come in. So again, great teamwork here. Some of the hottest hours I've ever been in to try to take care of them. But we would work with general surgery, and everybody takes an extremity and just washes them out. And again, these guys get testosterone after the inflammatory phase of injury is passed to sort of to replace their needs. So you see here is his lower extremity injuries, and you can see the blast. So that's his right lower extremity in close up there with the skin loss up into his perineum. Left lower extremity, see he's got a through knee amputation there. And there's his left upper extremity with his through elbow amputation. You can see that in this picture, his right hand was injured as well, but he didn't lose that. And this is the kid who's saluting you and saying thank you. He's awake before you roll into the operating room and take care of him. I didn't cover up his genitals here, purposely. I know you do that in most talks, but I think it's important that we remember this is a 24-year-old beautiful Marine the day before. Now he hasn't donated sperm. He's not going to be able to be a father. His injuries are so severe in his perineum as well as to the rest of his body. So traumatic injuries. Fifth patient, 23-year-old soldier, is also dismounted IED, so he was walking when the IED went off. He'd had bilateral lower extremity amputations, high BK on the left, a through knee on the right. He also had a subtroch femur fracture that had been ex-fixed, and he also had received the massive transfusion protocol. These multiple extremity amputations were not infrequent. There's been, I think at the point when I was there, 4 soldiers had survived 4 extremity amputations and made it through, but here's someone with 2 amputations. He had a right lower lobe PE 36 hours after injury, and I don't know that we know the reason for that. The military is looking into some of this, and they have some more thoughts on it than I do. I don't know their current thinking. Every Marine would tell you that they have 3 days of water and they go out on 4-day tours, so they're probably all chronically dehydrated. We think about them walking around. These guys are walking when they're injured, but if you remember that CNN reporter sitting on a Humvee, I think you may sit in vehicles. So I think they're dehydrated, and they're probably sitting in vehicles as they're out on tour. So I think these may be pre-existing DVTs, or maybe some component from the blast injury that does it. Maybe there's some lung injury. I don't know that we know the reason. Massive transfusion protocol. So he's getting whole blood, most likely. Does that have an effect? A lot of these guys are getting factors as well to stop the bleeding. So I just don't tend to see in my clinical practice PEs, symptomatic PEs, this early after injury. But we're seeing it not infrequently in the soldiers, so I'm not sure we know why, but there's something's going on. So the case for him, again with general surgery, washed out both his lower extremities, did some wound vacs for him. We're not going to fix his hip in lawn, so we're going to get him home, make sure everything else is clean and uninfected before you fix it. There's just a close-up. And it's important that, even after your 3rd and 4th and 5th debridement, you think you're sort of overdoing it, but you keep finding this blast injury it's gone through all the layers and as the infection evolves. And if you do close it, when they get back to the States, they'll call back and say that they're infected again and needed 3, 4, or 5 more washouts. Just another view of his extremity. I remember this day, someone walked in there and said, oh, this guy's lucky because he didn't lose his leg. 20-year-old Marine, dismounted IED, so he was walking, had a calc fracture, first metatarsal fractures, ankle fracture dislocation, and fasciotomies, and an IND, excuse me. So we'd take him to the OR on a Saturday, and there was planned flights back to the States. So he was supposed to fly on Sunday, but the plane was full, so he wasn't able to go. So we brought him back on this same Monday just to wash out his wounds again. We did close his fasciotomy, and hopefully that was able to stay closed. You can see sort of a close-up of his skin and his blisters from that injury. 7th case on this day, 30-year-old Polish soldier, had right upper extremity injury from a rocket-propelled grenade, had a humerus fracture, had an ex-fix, had a scapular fracture, pulmonary contusion with chest tubes, and a right tympanic membrane disruption. We didn't know this for a while. We finally found a Polish interpreter, and we're yelling at this guy. We thought he was just sort of being obstinate. We realized that his right eardrum was blown out. As soon as we moved the interpreter to the other side, we actually were able to communicate with him. So we washed out his right upper extremity, did a vac for him. His triceps was mostly gone, ulnar nerve was transected. So again, you can see that sort of staccato wounds as the grenades explode, and you get fragmentary injury. You even can see some more going down his chest there. His wounds were very, very wet and macerated, so we actually didn't end up vacuuming him. We ended up doing old school sort of sulfamylon dressing. We just would soak, I don't know if any of you have any plastic surgery history, but you can soak the Curlex in sulfamylon and just pack the wounds with that, trying to keep the fungal load down. We were worried about fungus for him. He's going to have a challenging humeral reconstruction. And then the final case was a 29-year-old in a convoy hit by an IED, so he was a mounted IED. He had bilateral wrist fractures, left had been open, right was closed. He had a pelvic ring that was treated closed. And he'd had some closed reduction and X-fix placed. So all we did was wash him out again and adjust his X-fix. So you can see his pins there and his X-fix. And then they fly home when they can. The coalition guys, again, the local guys stay, otherwise they go home to the States, and we've said where they go. So you can just see that, on the days they're going to fly, you see the stretchers just start lining up in the hallway. If you catch me later, I can tell you a story about one of the transport guys, which is sort of sad in its own right, but I don't think we have time here, but I'll convey it to you if you want. Just about, so you can see they're taking this patient, they just have an old school bus that's converted. It's not the fancy thing. You see this patient's going with wound vacs and ventilators. If they fly with the ventilator, they fly with an anesthesia doctor, an ICU doctor, or an ER doctor will be with them on the plane. You see us getting them under, then we sort of just hang them from the top of the bus and take them out to the airfield. And then it's C-17s back home as well. And it really is sort of an intimidating experience. I think you can kind of see down. There's a 747 off to the right that's a little bit bigger, but these planes are massive. And you can just see the volume of them lined up there, and just planes coming in all day and planes going out all day, just filled with the injured. So it's sort of daunting. Here's as you get into the inside of the plane. I thought this was one of the coolest things. One for me, I was able to go, the day we were allowed to go to Ramstein, these were all the kids we'd operate on for those 2 weeks, so you kind of could say goodbye to them. On the outer layer, I don't know if you can see it or not. I'll never figure out this button. But past the stretchers are rows of chairs. So the walking wounded fill the sides, and all the people in stretchers kind of line the airplane. Here's another view of it as well. Almost all the planes are from Mississippi or South Carolina, so they carry those flags. And then you notice the quilts. It's sort of an interesting thing, which is it's sort of cool. There's groups in the States that quilt these quilts, make these quilts for the soldiers. So every soldier going home gets a handmade quilt from an American for their trip home to help take care of them. And again, you see some people are intubated, some aren't, as they're heading back. And then just one last view of the inside of that plane. I want to just convey sort of the quality of care that they were providing to our soldiers. This is Stars and Stripes, which is the Army paper. This is, we had a VTC, a video teleconference, and every Thursday you sit down and you go through every single transfer. So Bagram and Kandahar on the phone, Landstuhl's on the phone, the transport C-17 team's on the phone, the transport team to the States is on the phone, and Brooke Army and Walter Reed are on the phone. So every bit of the care, and we go over every critically ill transferred patient. So it's really kind of a nice feedback loop on how did you do for these people. And we went through, it was 2 weeks worth of people because there was the Thanksgiving break that happened there. And at the end of the conference, somebody from Walter Reed, from San Antonio said Grigo went home. And half the room just broke down and started crying, and I wasn't sure what was going on. And I asked, and I went and found the article. So this kid, Grigo's 22 years old, shot in the chest in Afghanistan. This is, the medical history is from the newspaper, so this is the best I can do for you. Had a pneumonectomy in field. All the ventilators failed, but they couldn't oxygenate him. They couldn't keep him oxygenated. So this Dr. Wanek, a female surgeon in the Army, had anticipated this problem, had learned ECMO from her German counterparts, flew to Afghanistan, put him on ECMO. They put him back on a C-17, flew him back to Germany. Landstuhl couldn't do ECMO, so they took him to the local German hospital that could do ECMO. Once he came off ECMO to Landstuhl, and then they got him home to BAMC, and again, we found out that he was able to go home just before Thanksgiving and actually had Thanksgiving dinner at home with his family. So this is their so he's the first American soldier that anyone's known that's had been in theater, had a lung removed, transported out on ECMO to Landstuhl and to get home and to survive. So again, to me, it's important to just convey what's going on over there. I had the opportunity to be an interloper and to see some of it. But again, I think we're in great hands with these soldiers are amazing. It's a real honor for me to be there and just sort of participate in their care and to see it. And it was a real eye-opener to me that this wasn't a skirmish that was going on. I'll show some of these slides tonight because I think your parents may be interested that you're going into this sort of field, but we'll keep a lot of the circles on everything. So actually none of the pictures of that, but thank you very much. Just wanted to share that with you.
Does anybody have any questions for Dr. Zur?
So thank you. Maybe the most striking difference between us and the enemies we're fighting there overseas is that we're probably the only society on the planet that would do so much to save one life. It's really, really amazing to see. So thanks everybody. I would say that the resident presentations were really fantastic. So thanks to the residents. And thanks to Seth Bruce and Ted Gross. Ted has been sitting back there relatively quietly, but again, I know he put a lot of thought and a lot of work into doing this, and thank you to Sean. So one of the other comments I had is that it struck me listening to Dr. Alvine, again, we sort of think we're the first at everything as it comes up. You see a total ankle and you may forget that somebody had to do the early pioneering work and really gut it out with their patients to get us to the point we're at. And we hear a lot about evidence-based medicine, and sometimes I hear that and I'm like, wow, it sounds like when people mention that, they think that, we're the first generation to actually be using that. But I think Dr. Alvine's study on the ulnar nerve, which was a prospective study, was done probably before many of our residents were even born. So again, we stand on the shoulders of giants. We are the era of evidence-based medicine, but we haven't invented that. And then we went all the way to big data, Dr. Zur's first talk, which I think is a very modern manifestation of where we're all going to be going, proving that what we do is actually successful and cost-effective. So we've run the gamut today. And I have a few gifts for our guests. So, first I'll introduce a couple of resident awards. So we had two awards today. The first one is the Larnon Award, and it's for a spine paper done by Todd Blumberg, and that was predictors of increased costs and length of stay in the treatment of postoperative spine surgical site infection. So Todd, congratulations. And the second one was the Esther Whiting Award, which we give annually, and that's a historical paper, and that was written by Akash Gupta. Is Akash still here? Yep. And Akash's paper was The Axillary View, Arthritic Glenohumeral Anatomy and Changes After the Riemann Run Procedure. Congratulations. Each of you got a little honorarium there, and since you're taking Dr. Zur out for lunch, we know where that money's going to come from. I want to thank Dr. Alvine for making the trip out here. And we are going to have the good fortune of listening to Dr. Alvine discuss a little bit of the history of our department and his career as one of our graduates tonight. And for Dr. Alvine, we have a memento from his trip here. Thank you. And then it's been great to have Bob Zur here as our visiting professor. I think you'll see on the list in the pamphlet for today that he follows a long line of really illustrious physicians that we've had out here. And I want to thank you. It's been really great. And we're going to have the good fortune again, as Bob mentioned, to hear him again tonight at the Chief Resident Banquet.
Thank you very much.
So, thank you. We will see everybody in a few hours at the banquet tonight. Don't forget that the president is in town, and it is supposed to be kind of messy with the traffic downtown. And so Christine sent us out an email that listed the blocks, I think, that were going to be blocked off. And my recommendation is that everybody give themselves a little bit more time. So see you tonight.